Croeso cynnes eich I gyd, a very warm welcome to you all. It's nice to see you all here today. Welcome to a Wales and Africa Health Links Network, Hub Cymru Africa and Swansea University shared learning event. We are in for a very interesting and important topic being discussed today. So I'm just going to do a bit of welcome and some housekeeping. So welcome from me. My name is Julia Terry. I'm chair of the Wales and Africa Health Links Network, and I'll be shortly handing over to Julian from Hub Cymru Africa to hear more about the partnership work that we are all involved in. So just some housekeeping. First of all, if you want to access the agenda today, we've got them printed out on A3 in English and Welsh at the back of the room. We've also got them you can access via the QR reader on your phones if you want to do that. And if you're not sure, we've also got another version at the front if you want to come and check. Any questions about what's happening today, please do ask one of us. We've got myself, Julian and Simeon here, and a number of other trustees from Wales and Africa Health Links Network. Housekeeping. This is an event where we do have some times for tea, coffee and lunch. Lunch will be what we call a brown bag or a packed lunch, which will be delivered and available on the back table when we actually have a break for lunch. We have just a half-hour period. This is an event that is a kind of half-day event to give people a little bit of opportunity to travel either side of the learning. We're not expecting any fire alarms, but should the bells go off, then we'll just come downstairs and out to the front of the building. Ladies' toilets are opposite and gents are out of the room and to the right and follow the signs. I will let you know that in the ladies' toilet, one of the toilets is actually leaking, but it has been reported already this morning, so expect it as you go in. It's on the far stall on the right, just a heads up information. Any allergies that are in the room that you need to let me know about at lunchtime, please do so. And we are filming today's event. The camera is trained just here so that you know that, and the microphone is here only on the front desk. So if you've got something that you want to communicate, then you would need to come and stand at the front. So welcome to this shared learning event on antimicrobial stewardship, hosted by us, the Wales and Africa Health Links Network, in collaboration with Hub Cymru Africa and Swansea University. We are honoured to have you all here today as we come together to address one of the most pressing global health challenges of our time. We are very grateful to Hub Cymru Africa in their help facilitating the organisation and promotion of this event, and I would also like to particularly thank all our speakers today for their expertise and insights that they're about to share with us. Antimicrobial resistance poses a significant threat to public health worldwide, particularly in low and middle income countries where resources may be limited. However, we also recognise the immense value in sharing knowledge and expertise across borders to combat this issue effectively. Through initiatives with our health partnerships, we've seen firsthand the power of collaboration in addressing antimicrobial stewardship and its implications for healthcare systems. Throughout the course of this event, you will have the opportunity to learn from the experiences of our esteemed speakers, who will share insights from the front lines of antimicrobial stewardship efforts. From the experiences of several health partner links to practical applications in infection control and antimicrobial use in Nigeria, Malawi, Uganda and beyond. We aim to equip you with the tools and knowledge needed to make a meaningful impact in your own work and as you gain more knowledge on this important subject. Moreover, we're excited to introduce you to the resources such as the Global Point Prevalence Survey on antimicrobial consumption and resistance, which offers invaluable insights into identifying and addressing challenges in antimicrobial usage. Additionally, we will showcase some online training packages designed to facilitate collaborative learning with our partners, some of them in low resource settings, ensuring knowledge transfer is accessible and sustainable. As we delve into discussions, we encourage you to please actively participate. It's the old adage of you get out of something what you put into it. do share your experiences, do engage with peers. So at the moment there isn't a delegate list, but I know that within the room we have many, many experts, we have learners. Do get to know each other and find out what you can from each other. Let this be a space for meaningful dialogue and networking opportunities, so that together we can drive positive change and safeguard the efficacy of antimicrobials for generations to come. So thank you for joining us today. If you are thirsty during the event, please do just go and help yourselves to tea, coffee and water. I don't want you to be sitting there thirsty. And any queries during the day, please just come and tap me on the shoulder. I'm going to hand over now to Julia Rosser from Cymru, Africa.
Thank you, Julia. I might hand back in a few minutes as you're maybe sharing proceedings, I think, today, but and I'll help with some of the tech. Just to give a quick introduction, my name's Julian. I'm the Senior Development Support Manager at Cymru, Africa. And Cymru, Africa is a partnership between the Wales-Africa Health Links Network, the Welsh Centre for International Affairs, the Sub-Sahara Advisory Panel and Fair Trade Wales. So we've been working since 2015, supporting the international solidarity sector in Wales. So we support Wales-Africa linking, fair trade, we support the African diaspora to be taking action in solidarity with communities in Africa. And we do that in a number of ways. We do it by providing support, advice, networking events. We organise regular conferences. We support the Health Links Network with shared learning events. We have an interesting website with lots of resources and access to funding information as well. So please, if you're not familiar with Cymru, Africa, then please do check out our website, sign up to our mailing list, and you can get involved in activities and find out information about what's going on around the place. I've got a couple of things to mention. One is that we do run a volunteer placement program. So if anybody is working with an organisation which would benefit from having some volunteer placements, then please do get in touch. We've got a number of particularly postgraduate students who are keen to do short volunteer placements. So if you have a project and you're able to manage a volunteer placement, then please come and talk to me, or you can email inquiries at hubcymruafrica.org.uk. And finally, I was going to say that we are considering, a number of people have been talking about setting up a community of practice, so that groups in Wales who are working internationally can talk together and share best practice in antimicrobial stewardship. So that's something that we'd like you to have a think about today. We do have a sign-up sheet, I think, is it around the place? We will be taking names and contact details from people who are interested in getting involved further in talking about antimicrobial stewardship. And so please do fill in a form or come and talk to me, and we will see what we can do. So that's everything from me. Julie, would you like to say, speakers are self-introducing, aren't they?
Yes,
so,
I think we'd ask all speakers just to introduce themselves briefly and their current role, and so I'll just say, Kerry, over to you.
Thank you very much, and thank you very much for the invite as well. So my name's Kerry, I'm consultant antimicrobial pharmacist in Aneurin, and my experience of global health work is through the Malawi Wales Antimicrobial Pharmacy Partnership that you're going to hear about a bit later, so I won't give you too many spoilers. So the idea is for me just to give you a little bit of scene setting as to why this is important. So hopefully this concept doesn't come as new to any of you, but we'll just go over a few key facts and figures as to why we all really do need to be incorporating this into our work. So we know that antimicrobial resistance is a natural phenomenon. So anytime an organism is exposed to an antibiotic, they are at risk of developing resistance. And the more microorganisms are exposed, then the higher the risk of resistance. So we can see there that even if it's a simple infection, like a urinary tract infection, a respiratory tract infection, even up to 12 months down the line, that person is more likely to be harbouring resistant organisms. So, even if you just had that one course for 3 days, that you're more likely to harbour resistance. And the more we use them in terms of number of courses and duration of courses, then the higher the risk. And the impact that has, currently, it means that we are having to use agents that maybe we don't really want to be using, so a broader spectrum of cover, or combination treatments, or antibiotics that have nastier side effect profiles. So there are knock-ons in terms of what options that we have to use for individual infections. It also increases the length of stay in hospitals, it increases healthcare costs, and also, most importantly, increased mortality. So resistance already kills more people than HIV, TB and flu combined. So when you think of all the effort that we put into those individually, AMR we need to be putting significant resource into. Long term, if we don't have antibiotics available, then for salvage therapy, then we really can't do things like complex surgeries and chemotherapies and things that rely on us having antibiotics available to treat any infections that come through. And that means that will then also follow through into decreased life expectancy, either from not having those interventions available, but also people dying of infections that are currently treatable. So we could be going back to more of a Victorian age if we don't try and halt this and get new antibiotics. And globally, it could cost the economy £66 trillion in lost productivity by 2050. So this comes from this report, which is getting a little bit old now, from 2016, but basically says that if our current rates of resistance continue to grow and are not mitigated, then by 2050, AMR will be killing more people than cancer. And that is really significant in terms of, again, when you think of the amount of resource that we put into treating cancer, we need to be putting the same amount of effort into AMR as well. And unfortunately, this paper that came out in 2022 modelled loads of data internationally and looking at what is the actual real burden now. And it actually found that there were 5 million deaths associated globally with AMR, of which 1.2 million were directly attributable. So they concluded that AMR is already a leading cause of death around the world. And unfortunately, from that graph, you can see that that burden of disease is highest in sub-Saharan Africa. Now, when we have a look a little bit in more detail at those kind of those figures, we can see that, okay, we've got the green countries of sub-Saharan Africa regions, we've got Western Europe where we are, and we've got Australasia who have the lowest burden of disease. And you can see there, actually, the death rate is highest in Western Europe, the death rate involving infection is highest in southern sub-Saharan Africa, but the resistance is greatest in Western sub-Saharan Africa. But you can see all of those figures of death rate associated with resistance or attributable resistance are much higher in sub-Saharan Africa than in kind of Western populations. And to bring it back home, I'd just like to share with you some of the data that we've had through our project. Please don't share this because it could be published by the in-country team. But this is from one of the tertiary referral hospitals that we're working with in Malawi. And this was a January to August 2022 data. For those of you with good eyesight, you will see that the isolate numbers there are very, very low. So we've got a bias here immediately because they're only testing the people that have got really severe intractable disease. But what you will then see is that we've actually got some E. coli's that are not susceptible at all to cefotaxime or ceftriaxone, which are some of the main antibiotics that have been used, and also not susceptible to cotrimoxazole or ampicillin as well. We've got some susceptibility, but not much, 5 or 6% to ceftriaxone, and that is the main antibiotic that is used across Malawi. So if we're going to give a patient antibiotic, that's probably what they're going to receive, and it's probably not going to work in the majority of cases for these isolates. Unfortunately, amikacin would be a really good option in this cohort because we've got really good sensitivity rates there, so 85%. But A, we've got issues with availability, and B, we've got issues with being able to monitor the drug safely to ensure that when we use it, the levels are not going to be toxic. So we've got things that we could be using, but they're just not suitable for use in the context. So this shows you some of the issues that we've got around stewardship in lower income settings. Now, the World Health Organization has recognised this as a significant problem. So going back to 2016, they said it's a slow motion tsunami. In 2019, they've added it to the top 10 threats to global health, alongside a number of other infection-related issues as well. And then more recently, coming out of the pandemic, there's been a kind of resurgence of, an urgent need to address this. So, saying that this is a silent pandemic, it is here already. We don't recognise that it's necessarily here already. But again, we can kind of align some of our messaging to the pandemic, so no one is safe until we're all safe. So actually, if we've got those sort of resistance levels in sub-Saharan Africa, then they will very easily be shared and imported and kind of spread more globally. So this is a global problem, and we need to take coordinated action to address it. So what the World Health Organization did in 2016, they came up with an action plan to try and address antimicrobial resistance, and then various countries, not every single country yet, unfortunately, have developed a resistance strategy. So you can see there, Malawi have their own, and they have a point in there about international collaboration. And then in the UK, we have a 20-year strategy broken down into 5-year chunks. So we're just about to hear our next kind of 5-year plan in April. But one of the key things in there as well is about supporting international collaboration as well. And it's not just about stewardship. As we see in this country as well, stewardship, infection prevention and microbiology all work hand in hand, and no one of those can work in isolation. So it's really important that we all work together in a multidisciplinary capacity, because we know that prevention is better than cure. Water, sanitation and hygiene are actually the key drivers of AMR in lower and middle income countries, not so much antibiotic use necessarily. Vaccination, we know that that's really important, infection prevention and control, because if we actually don't have an infection, then we've got nothing to treat. So that is really key. So what is AMS? Well, there's loads and loads of different definitions. This is the World Health Organization one, which is quite kind of broad and loose, but effectively it's around supporting healthcare professionals to follow guidelines for prescribing and administering antimicrobials. What we actually use in practice is a lot of kind of different interventions, all that are trying to kind of optimize antimicrobial use. So using guidelines, surveillance, kind of having information and data on how our antibiotic consumption, ward rounds to improve stewardship, educating our kind of peers to make sure that we are using antimicrobials appropriately and that they know why as well. And also things like public engagement. But there are significant barriers in lower and middle income countries, especially around lab capacity. So as I said before, the numbers of isolates that they were testing, very, very, very small. So there's a lot of work going on in the space at the moment to try and improve that capacity, both from a microbiology perspective and also in terms of being able to monitor some of the antibiotics too. Availability is a key one that I'll touch on in a moment. Access to up-to-date evidence and guidelines, and sterility of surgical procedures, for instance, as well. So lots of other issues that we need to take into account, which are different in these contexts than they are necessarily in the UK. So I mentioned availability as a key driver for us. And the supply chain reliability is very, very variable. And that's going to vary between countries, but it's also going to vary within countries, and even sometimes within sectors. So we found that some of our hospitals have really good supplies of one antibiotic, some of them have been given a different antibiotic. And that means they have to be very agile in terms of recommending treatments, because depending on what they've actually got in stock. There have been some anecdotal reports of attrition as stock moves through the system. These very poor countries, and people are kind of, unfortunately trying to sometimes, taking some of those supplies away. So actually the amount that comes into the country is not necessarily the same as the amount that is available to the end user. So what we've actually come across in one of our main hospitals is they actually request that for the IV antibiotics, whenever they order some, they bring down all the empty vials to make sure that they've been used before they supply more stock. Substandard and falsified medicines are really, really important, because actually if you've got an antimicrobial that hasn't got 100% of the active ingredient that you're expecting, then you're potentially exposing that patient to a subtherapeutic level, which is just going to drive more resistance. And then also, we have got some new antimicrobials, but even to the NHS, they are very expensive. There is no way that they are currently affordable to lower income countries without access, programs. And also, we're lucky at the moment to be working with public sector hospitals, but not all healthcare is going to be public sector. Some of it will be paid for. And can patients afford antibiotics? Can they afford to pay for the whole course? Because if they can't afford to pay for the whole course, then we're going to get resistance coming through if we're not actually treating them accordingly. And these are some of the sort of issues that we've come across. So on the left-hand side, we've got a picture of the stock in one of the dispensaries. So we've got a really good stock of coamoxiclav, which is a broader spectrum antibiotic. We haven't got any stock in there of flucloxacillin, which actually is a much narrower spectrum antibiotic that we would like to use preferentially for a lot of infections. So we are driven automatically to using something that is broader spectrum. And on the right-hand side, we've got the meropenem stock. So this is a 1,000-bedded hospital in the capital city with a population, I think, of around about 6 million. And we've got 11 vials of meropenem. So how do we judiciously use that and make sure that that actually gets through to the patients that really need it? And actually, their management of meropenem is better than ours is in the UK because of the scarcity. So actually, they can only give meropenem to a patient if they've had a positive culture that is susceptible to meropenem and nothing else. So actually, their stewardship is better than ours from that perspective. And the reason the supply chain is really, really important is that we want to be trying to use as many antibiotics in the access category as possible. So the World Health Organization split down antibiotics into these 3 categories. And effectively, when you go from access to watch to reserve, you are increasing the spectrum of activity and you're increasing the potential for resistance as well. So we need to be trying to use as many as possible in the access category. But as you can see, if in Malawi we are mainly using ceftriaxone, we're already in the watch category. It also then gives you very little space to actually escalate that patient onto an alternative therapy if they fail to respond. So some of the key concepts of antimicrobial stewardship are only using antibiotics when absolutely necessary. So making sure that, if we can take a thorough diagnosis to confirm infection, that's really key, because actually, is it an infection? Is it something completely different? Do we really have to be using antibiotics at all? In some instances, if we've got something like urinary infection, do they actually need antibiotics? Could they take a painkiller instead, maybe? And if we do need to use antibiotics, then making sure we're giving the right drug at the right dose for the shortest effective time. And I think we've all found in whatever our roles, the behaviour change is hard, and AMS is all about behaviour change, but it also is everybody's responsibility. So what we need to see is a change in clinical practice coupled with public engagement as well, so that the public understand why we're asking them to do some things. So some of the resources that I thought I'd flag to you is the Antibiotic Guardian campaign. So this is run by the UK HSA, and they have come up with specific pages for African citizens and also organisations within Africa as well. And then also at the back, we've got representatives from Cardiff Uni, from the Superbugs online that you can have a chat to in the break and hear about what they're doing as well. One of the things that you may want to share with some of your partnerships as well is this MOOC. So this is from the British Society of Antimicrobial Chemotherapy, but it's mainly been designed by the Infection Control Africa Network and the College of Medicine in University of Lagos. So it is designed by Africa for Africa, and it's all about AMS. So this is open access. It is 3 weeks of 3 hours per week of learning that is out there and available and free. So I'd recommend that people go and use that if you can. And then the other important thing that we are trying to do within our project as well is make sure that we've got governance around AMS, and that is really, really key. So we need to make sure that we've got structures that are present and also functioning. So sometimes we've got structures that are present but not necessarily functioning. We also need to make sure that we've got data and key performance indicators. So we're going to hear later about prevalence surveys, and one of the things that we're trying to incorporate into our project at the moment is collecting some consumption data as well. We need to make sure that what we're doing is sustainable and funded you know, because there's no point in going in there doing this wonderful piece of work and then it just falls flat. You know, we need to make sure that how we are building things is going to be sustainable. And then we're also going to hear later about accreditation, about kind of, you know, how good are our services, how can we benchmark. So I put a couple of toolkits up there. So we've got World Health Organization one and a CW PAMS toolkit. So these are aimed at organizations and can be used by organisations in setting up their stewardship programmes. So I'm going to stop talking here, but I would say, yes, we are dealing with the silent pandemic, but it shouldn't be silent. We need to make sure that we are spreading the word about this and raising the profile, because, as I said, no one is safe until we are all safe. Thank you very much.
Thank you very much indeed. That was extremely helpful start to the day. So just to let you know, we're going to do questions and answers at a set point in time. So Angela, if you're ready to come up and start. If you've missed tea or coffee, this is an ideal opportunity to go and grab one if you didn't manage to earlier. So we are recording this as one whole session, which we'll be able to pass you the link later. Do please scribble down questions that you may have during so that you can come back to them, and we will be making all the slide presentations available for you. So unless anyone's got any burning housekeeping questions at the moment, we will be ready to go in just a moment. I'm pitching a more tea coffee.
Can you all hear over there? Are you able to hear?
Don't be shy.
Not too loud.
No, I'll try and... Do you think, is it possible to have a little...
Yes, so in terms of the room, I know you've got both streets. There's plenty of seating over this side, so we're going to warmly welcome you over this this side, please. Brilliant, that's really helpful. Thank you very much. Stuff there, that's all right. That's lovely. Thank you very much indeed.
Okay, I'll begin in the interest of time. Good morning, everyone. My name's Angela Davis. I'm a professor here in Swansea University Medical School. My background is as a consultant medical microbiologist with a particular interest in education in antimicrobial stewardship. Thanks very much for the invitation to present here today and tell the story of WaAHLN, which is a Wales-based community of practice in AMS education, and our collaboration with colleagues in Nigeria to share good practice. So I'm going to start by explaining how WaAHLN actually came into being and a bit about its activities here in Wales, and then go on to talk about our Nigerian collaboration. And I suppose one of the things that I want to get across is that this model, which I'm going to describe, of a virtual community of practice, is something that can be applied anywhere in the world, including in low-resource settings. So the story of the WaAHLN project began with this document, Together for Health, Tackling Antimicrobial Resistance, which was published by the Welsh Government in 2016. And this was Welsh Government's response to the AMR crisis, and it laid out the steps that the Welsh Government was going to take. And one of the very important elements of this plan was the commitment to appoint a new cadre of antimicrobial pharmacists to all the health boards in Wales. At that time, the specialist antimicrobial pharmacist role was a relatively new one and not so familiar. They are now absolutely the linchpin of antimicrobial stewardship efforts in hospitals across the UK, but they were less familiar then. A colleague of mine, who is an antimicrobial pharmacist, allowed me kindly to see her job description, and you can see these are some of the elements of the job description, and I'm sure you'd agree that they are pretty challenging. For example, influencing medical consultants on the management of complex cases, challenging their treatment choices, deputising for microbiology consultants, and interpreting microbiology results to provide advice. That's quite daunting for a newly appointed pharmacist in antimicrobials, So it's perhaps not surprising that the Wales Pharmacy Group around this time contacted me and said, help, we know all about antibiotics, but we don't really know about interpreting microbiology results and laboratory testing in microbiology and all this sort of thing. Can you help us? So of course I wanted to help. I was mindful that my experience was mainly in undergraduate medical education. So I did a little bit of looking into the evidence base for continuing professional development for healthcare professionals, which is a quite different group from undergraduate medical students. If anyone is interested in this evidence base, there's been a subsequent very useful review of it carried out by the General Dental Council, which you can find there if you're interested. What the evidence base for CPD for healthcare professionals shows is that there are a few elements that are really important. First of all, they have to be based on adult learning principles. These professionals are bringing their own prior extensive experience, so the learning needs to be very relevant to them. It needs to be real life based on scenarios that they might encounter. There needs to be a combination of learning approaches, which should be as interactive as possible. Well, that's always good practice in education. Interprofessional education is recognised as being very beneficial for team working, and we've heard from Kerry how antimicrobial stewardship is very much a team enterprise. So that's really important. And peer learning is important for people who are working either on their own, in their hospital, or in a very small team. That's very valuable as well. And lastly, sustained support. We don't want people to go home after they've had this education and then forget all about it and never apply any of it. And there are different ways that this can be addressed as well. And I sort of summarise all of this as what I call the 4 I's, which are interest, interactive, interprofessional, and iterative. So I wanted to make sure that whatever I provided was going to meet this 4 I's requirement. So the initial outcome of this was this course, which has been running at Swansea Medical School since 2015. It's a week-long course, especially tailored for healthcare professionals involved in managing infection. And they can be from any professional background. And I wanted to make sure that we were addressing the 4 I's in this course. I knew we had number 1, because the course was provided in response to a request from learners and the content was planned along with them, and it was very much about real life scenarios. I knew we had number 2 because we made a point of making this course very interactive. You couldn't sit for a whole week in didactic lectures, it would be mind numbing, so we have as many interactive and practical sessions as we possibly can. This is an example of our professional learners looking at gram stains, interpreting the microscopy and applying it to clinical cases, and this is an element of the course that they really value. And we have different games and puzzles just to keep things varied and to keep things moving. Here are some top trumps that these are homemade by me on antibiotics, but I subsequently got some funding thanks to the Microbiology Society to professionally produce these, and hot off the press I now have sets in Welsh funded by the Coleg Cymraeg. If anyone is interested in these, come and find me afterwards. Thirdly, interprofessional. Well, you can see that both our teachers and our learners come from a quite wide range of backgrounds, and again that's been an aspect that is highly valued in feedback. I won't dwell on this aspect as we want to get on to our Nigerian collaboration, but both the interprofessional and the peer learning aspects are some of the things that people really appreciate. But what about this number 4, iterative? So this, I thought I have to address this about the sustained support. So it was very evident that the people that attended this course and participated in it were highly engaged, expert, dynamic people who were going back to their health boards, and they were then educating all the staff in their health boards about antimicrobial stewardship. And they were doing a fantastic job of it. So I thought, well, how can we support that activity that they're all going out to cascade everything that we've been discussing in this week at Swansea? And that was the origin of the project, a website was created for AWARE, which is, there's its front pages, its home pages there, antibioticaware.com. And on this, we have put loads of different resources that both created by myself and also other members of the AWARE virtual community provide their resources, if they want to voluntarily, to share with other members of the group, so that we don't have to reinvent the wheel every time we need to do some teaching. There are animated videos there on different topics in infection that can be used for teaching elsewhere. This is all online and freely available. There's a fantastic series of podcasts. I think there are over 30 of them now, and these have been created by our talented trainees in microbiology and infection at Swansea Bay. And it's been a great learning experience for them as well to create this series of podcasts, which again, our AWARE community can use in all of their health boards. We've got a Twitter account to share links to resources and information. We carry out an annual survey. This is in order to capture the activity, the educational activity that's going on by members of the AWARE community, because this is not captured by anyone. It's kind of part of their role to educate people in their health boards, but that data is not really captured. So we try and capture annually the impact in terms of the number of individuals that they have managed to reach. And over the years that we've collected this data, you can see that the numbers of individuals being reached across Wales is growing and growing. And that also enabled us to show that during the pandemic, the members of the AWARE community were able to reach more healthcare professionals, not fewer, even during the pandemic, thanks to the rise of virtual platforms for education. We've run webinars and other events. So, until the end of last year, I held the role of Vice President for Learning and International at the Royal College of Pathologists. I've just demitted from that role. And during my tenure, the National Postgraduate Medical College of Nigeria contacted the Royal College of Pathologists and said, can you support us in providing some antimicrobial stewardship education? And of course, I was very keen that we should respond positively to this request. But what I knew I didn't want us to do in RC Path was to just produce a series of online lectures that people could watch. There's loads of material already online. Kerry's already highlighted some of that. That already exists, that's already excellent, and I didn't see what value that was going to add if we just did that. So what I wanted us to do was to co-produce and co-deliver some interactive online webinars together with our Nigerian colleagues. And so the format that we opted for was to, with our Nigerian colleagues, to pick a series of topics that we wanted to cover. And then we invited Nigerian experts to present on that topic alongside people from the UK, giving the UK perspective on that same topic. So it was almost like a compare and contrast sort of exercise. And that was able to stimulate then a discussion and a debate about different approaches and different ways of doing things. And people watching online were able to ask questions and participate in that discussion. These are the topics that we decided we were going to cover, and this last one down here was where I made my contribution, talking about our AWARE virtual community of best practice as something that is a model that could be done anywhere in the world, and which I also pointed out that AWARE, that community of practice, has operated without one single penny of funding. It's not something that requires a huge amount of resource at all. What you need is dedicated, enthusiastic, dynamic people who want to participate and who want to do it. So it is very much something that could be done anywhere. I want to highlight our contributors. On the left, I have our Nigerian colleagues from the National Postgraduate Medical College of Nigeria, and the Clinical Microbiology and Infectious Diseases Society of Nigeria. And I particularly want to highlight Dr. Kenneth Iregbu, consultant microbiologist who was our project lead for Nigeria, and Professor Samuel Taiwo, who has very kindly done us a video, which we're going to get to watch today. I'm looking forward to seeing that. And our other Nigerian experts on the left. And on the right, we have our UK contributors. And I was very proud and delighted that Aware Wales was able to work with RCPath to provide the contributors from the UK side, and all our contributors, almost bar one, were from the Aware Wales virtual community. The eagle-eyed amongst you will spot Professor Byd-eang down here, who's one of the UK HSA leading lights in AMS, but the rest of us were all from the Aware Wales community, working with RCPath. RCPath provided the admin support and the technical support. And the collaboration between UK and Nigerian speakers was something that was commented on very much in the feedback and especially valued. People really liked hearing both perspectives. And here are some of the feedback of participants saying how they would use what they'd learnt and implement it in their setting, which ranged from quite small hospitals to the Ministry of Health, Agriculture and Environment. So that was very pleasing. The whole lecture series is available on the RCPath website. That's freely available if people want to go and look at those. I just added this poster of our project. This is just to remind me to add that this project was so well received that RCPath has decided to expand it and do similar work with other of our international regions, because we have international members across the world. So we are planning a new series of this project with other countries and regions. So those of you from Aware, watch out, I will be coming after you shortly to ask you to contribute. That's going to happen in the summer. So to summarise, I've listed the 4 I's that are needed as the evidence base for good healthcare workers CPD. Interest, interactive, interprofessional and iterative. And especially for today, I've added a 5th I, which is international. It can be international, and what I do want to stress is that this model is something that could be replicated anywhere if you've got enthusiastic people that want to do it. So that brings me to the end. Diolch yn fawr. Thank you very much. I'm happy to have questions now.
Wow, thank you very much, Ankara. That was extremely informative and helpful. We are learning a lot about lots of already available resources. So we are about to hear from Professor Taiwo via video, which is just coming up shortly. We can adjust the volume as we need to. So I'll just be looking around avidly to see how that's...
Yeah. You can look avidly, that's supposed to be...
Hello everyone, my name is Samuel Taiwo. I'm a professor of medical microbiology at the Uganda University of Technology and Teaching Hospital, Bomoso, Southwest Nigeria. In this short presentation, I'll be talking about the challenges of antimicrobial stewardship in Nigeria. This is the outline. The global research on antimicrobial resistance study that was conducted in 2019 and published in the Lancet of 2022 gave a very good estimate, which is still the best estimate on AMR issue to date. And it shows that AMR is a global challenge. In 2019 alone, approximately 5 million people died or suffered from drug-related resistant infection. And AMR was directly responsible for 1.27 million of those deaths. 1 in 5 of the deaths occurred among children that were under 5 years of age. So, as it were, antimicrobial resistance in terms of mortality and death is just behind stroke and ischemic heart disease among all human diseases at current. In the same ground study in 2019, Nigeria accounted for 263,400 deaths that were associated with antimicrobial resistant infections. 64,500 of those were directly attributed to AMR. Among 204 countries that were in that study, Nigeria was 185th highest in terms of each standardized mortality rate per 100,000 population. When you come down to the Western Sub-Saharan Africa, among 19 countries, Nigeria occupied the 13th position in relation to each standardized mortality across those 19 countries. So these are big issues in Nigeria. The number of AMR attributable and associated in Nigeria has overtaken all other diseases, both infectious and non-communicable diseases, as can be shown on the left side of the slide here. And 5 pathogens have been identified to be responsible for this AMR-related infection and mortality: Streptococcus pneumoniae, Klebsiella pneumoniae, Escherichia coli, Staphylococcus aureus, and Group B Streptococcus, which are the pathogens that are commonly recovered from AMR infections of the respiratory tract, the lower respiratory tract, meningitis and other CNS infections, bloodstream infections, and abdominal infections. Now, how has Nigeria responded to the claims of AMR? Since the 2012, when the roadmap for the global system for AMR was developed, up to 2015, when the global action plan was developed by the WHO and approved by the United Nations National Assembly, Nigeria was one of the few African countries in 2017 that developed their own national action plan. And this was following the situation analysis and mobilization of the various sectors that were involved in developing a One Earth national action plan for 2017 to 2022. That action plan has been implemented to a large extent, and the National Action Plan 2.0 is already in the pipeline for release. So we have the governance structure, are the 5 pillars in those 5 focal areas of the National Action Plan, including the antimicrobial stewardship pillar. And this is overseen by the National Antimicrobial Resistant Technical Working Group that reports to the AMR Coordinating Center that is domiciled in NCDC, Nigeria Center for Disease Control. And we have a line of reporting or a line of communication to the National One Earth Technical Committee and the National One Earth Steering Committee of Ministers who report to the Presidency, which is the highest approval body. And when we look at the NAP 1.0 implementation, we had 44% in the assessment. And when you break that down, you see that antimicrobial stewardship, research and innovation are actually behind in terms of implementation compared to the others. So, in terms of implementation, antimicrobial stewardship implementation, the NCDC effort has been well acknowledged. We've supported about 52 hospitals across the 18 out of 36 states of the Federation, supporting those hospitals to establish antimicrobial stewardship program and also to start some implementation of such activities. And such support that they give include providing AMS guidance documents, which were not locally derived documents, but from elsewhere, and training and supporting center to conduct antimicrobial use, point prevalence survey, and antimicrobial consumption survey support, and also linking to them with funding partners like Commonwealth Financial Association, CW funds, and Yearly Fund, helpful in developing the laboratory. But in terms of teaching of antimicrobial stewardship, I think most of the efforts in getting this to the end users, where these stakeholders, is Cymru's effort. Cymru is the Clinical Microbiology and Infectious Disease Society of Nigeria, which is an association of clinical microbiology and infectious disease physicians and others that have interest in the infectious disease matter in Nigeria. And in 2018, the Cymru executive set up the National Antimicrobial Stewardship Working Group called NASWOR, and gave them the mandate to develop a guidance document that will enable uniform implementation of antimicrobial stewardship programs in the three-tier system of healthcare delivery in Nigeria. So these members of this committee or this working group started by conducting a survey on the 20 selected healthcare facility to know the gaps and challenges of antimicrobial stewardship implementation in these hospitals. And they found that only 30% of those facilities actually had an antimicrobial stewardship committee, unless about 10% had leadership commitment to antimicrobial stewardship program. So using this as a working information, the background information, and through the support of WaAHLN, this group was able to develop a Cymru manual for antimicrobial stewardship programs in Nigerian healthcare facility, which was launched during the Cymru conference in November 2023. So it's a working document that will assist facilities to establish, to implement, and to sustain antimicrobial stewardship program in Nigeria. Let me say that Lagos State University Teaching Hospital has been in forefront of antimicrobial stewardship implementation in Nigeria. And in October 2023, they received a level 2 certification of the British Society of Antimicrobial Chemotherapy Global Antimicrobial Stewardship Accreditation Service in 2013. So that in October 2023. So that is a very good effort of that institution. The lady chairperson of the committee in Lagos State University, Lagos University Teaching Hospital, is the vice president of Cymru. So Cymru's effort has been well appreciated as far as AMS implementation is concerned in Nigeria. Now, so what are the challenges that we have identified? One is a lack of or inadequate knowledge. So in some cases, there are lack of that knowledge and awareness, while in some, just knowledge is not adequate enough, particularly by prescribers who are majorly doctors in Nigeria, but other important stakeholders like pharmacies, like nurses, laboratory personnel, facility administrators, including patients and caregivers. They have good knowledge of AMR, but they don't have knowledge of AMS. So there is a disconnect between knowledge of AMR and knowledge and awareness of AMS. There's also lack of, in some cases, or inadequate human and financial resources. Prescriber opposition to antimicrobial stewardship implementation strategies in centers where we have AMS program. This is one of the issues, particularly opposition to the front-end strategies like formulary restriction and pre-authorization. This is usually very well resisted by the clinicians because they feel that their autonomy over prescription is taken away. It's a passive autonomy, or that they are not ready to do that. And of course, there is a poor laboratory support in terms of quality, in terms of service, in terms of capacity, and also where there are laboratories, we have underutilization of microbiology laboratory by physicians, which we have reported on in the past. And this impedes diagnostic stewardship, which is an important component of antimicrobial stewardship. Of course, we also noted that there's a poor coordination between the Nigeria Center for Disease Control and Prevention and key associations and societies that are involved in infectious disease matter, particularly with regard to antimicrobial stewardship implementation, such as the Medicine, Nigeria Society for Infection Control, Nigeria Infectious Disease Society, Epidemiological Society of Nigeria, and Pediatric Association of Nigeria. These are key infectious disease society that we think should be well coordinated with the NCDC so that we can have better implementation. What are the way forward? We have intense and sustained education and training activities for prescribers and other stakeholders, including the facility administrators. And of course, we need our government to give enough counterpart funding to AMS implementation in Nigeria through the healthcare facility administration. Currently, we receive more support from international partners, and we need to also show more commitment so that we can take ownership of this program. But we still need more international partnership to support healthcare facilities so that we can establish, implement, and sustain AMS program, as well as help in laboratory equipment and raising standards so that they can support this through diagnostic stewardship as well. And of course, there should be improved coordination by the NCDC with important stakeholders, especially key associations and societies like the medicine. And lastly, our government must regulate the drug and antibiotic supply chain in Nigeria. Currently, this chain is very chaotic, and agencies such as National Agency for Food, Drug Administration and Control and Pharmacists Council of Nigeria, which are agencies responsible for drug supply, should be empowered to be able to do this so that we can take away these antibiotics from the easy access to the populace, which we also assist in the antimicrobial stewardship that we're talking about. I want to thank Professor on this for giving me this opportunity to make a short presentation, also to thank the Wales and African Health Links Network and the management of my teaching hospital. Thank you for listening. Over.
Our thanks to Professor Samuel Teo, and Julie, if you want to come and get ready.
Yeah, videos are. Just do this.
Hello everybody, so I'm Julie and I'm going to just give us our experience to date as an introduction or an update to some of you on our Malawi Wales project. It'll be a joint session, so I'll be covering the background to the project on Malawi, and then William, our lead pharmacist in Malawi, will be doing a short video to introduce exactly what the project is about and where we're up to as well. And then I will just finish off with a bit around how we collaboratively work within the partnership as well. So I'm Julie Harris, I'm a consultant antimicrobial pharmacist working here in Swansea Bay, and I'm one of 5 UK pharmacists, including Kerry in the corner there, working on this project. So this is the CW PAMS project, and just to introduce CW PAMS to anyone in the room who's not aware of it, it stands for the Commonwealth Partnership for Antimicrobial Stewardship. It's a global health programme that's funded by the Fleming Fund and is managed then by CPA, the Commonwealth Pharmacists Association, and FECT, which most of you probably are aware with. And it's got, you know, and it focuses very much on antimicrobial stewardship, as the name suggests. And its overall aim is to improve antibiotic prescribing in low to middle income countries through implementation of protocols, evidence-based practice and other tools to help support prescribers in those countries as well. But also an important aim actually to improving the capacity of being able to do surveillance on exactly what antibiotics are being prescribed, what the patterns are like, to then to be able to identify targets to work on to drive that quality improvement forward. So the partnership formed from members of the Welsh Antimicrobial Pharmacist Group, which I'll explain in a second, around Kerry and Charlotte picking up the grant application call from a CPA and then going into that process. So Charlotte, one of our lead partners, has got personal connections to Malawi. She's married to a Malawian and spends a lot of time in the country visiting families. And so it was an obvious choice for the partnership. There was also no Malawi partnerships within CW PAMS at that time as well. And so quite quickly then a partnership was formed with the Pharmaceutical Society of Malawi to bring the two groups together. I should mention as well that pharmacy is a very new profession within Malawi. They've only been training pharmacists within country for the last 10 years. And so it is a growing profession there. At the moment, they are still very much regarded as kind of a supply function, storekeepers. Their role is very much in the dispensaries, performing that kind of role, procuring antibiotics and supplying as well. They haven't established to clinical pharmacy ward-based roles like we have in the UK, but I'm sure that that is what we are aiming for. So a big part of this partnership is actually promoting the pharmacy profession in Malawi as well, and showing what they can do around this and other areas from a more clinical basis as well. So this is the second stage of the project. The first project was completed in 2022, but William will tell you more about that in a second. So a little bit about what our network is here in Wales. So as I said, this is a function of the Welsh Antimicrobial Pharmacy Group, which is a network of specialist antimicrobial pharmacists and technicians working across all the health boards in Wales and Public Health Wales as well. So within that team, there's 5 of us from various health boards across Wales working on this project. But as a wider group, we do also have additional support from Cardiff University in terms of research, a number of Welsh clinicians, including microbiologists, oncologists, and the wider group from the Welsh Antimicrobial Pharmacy Group as well, for any offshoot projects that need more resource being put into them as well. So I think we're well supported as a team as well. So just to quickly introduce Malawi to you. So it's called the warm heart of Africa, and once you arrive, that's quite evident from the people there as well. It's a beautiful landlocked country with a large freshwater lake called Lake Malawi. It's got a large population. This is data from 2019, where there was 18.4 million at that time, and that is set to double by 2038. And approximately 83% of the population live in the villages in rural areas with various access to electricity and water, etc. as well. If we compare a bit between Malawi and the UK, you will see there that boom in population is explained by the fertility rate, which is double the UK rate as well. And sadly, they have a very high mortality rate within infants and young children within the country as well, with an overall life expectancy that's significantly lower than the UK as well. And just to highlight really the differences, we're working with hospitals in Malawi, and so just to kind of illustrate the different challenges they see in terms of their healthcare populations as well. It's a younger population, and as you see from this 2019 ranking here, a lot of their challenges are still around infections, malaria, TB. They have done a lot of work on HIV and AIDS, and as you can see, that dropping down the ranking in that 10-year period. And so some of the complications of HIV and AIDS are less so there now, but it's still a battle as well. They don't have some of the older diseases that we kind of struggle with, so it's a very different population within the hospitals often as well. Kerry has covered quite a lot of this around, but we visited Malawi in June as a UK team, and we visited all of the new hospitals facilities that we were bringing online. And the purpose of that visit was that we had proper context around the country, the challenges, how the healthcare system worked, to be able to then effectively advise, on potential interventions and support the Malawi team as well. Kerry's already picked up on the massive supply problems, how inconsistent they can be from hospital to hospital, and how that leads people down a single line in terms of antibiotic prescribing, and I'll show you some data around that as well. But other things that struck me on the visit was the laboratory provision is very, very varied again across the sites. Some of the smaller district hospitals we visited hadn't been able to do a full blood count in a year. Microbiology provision varied. Some hospitals had Fleming Fund input and so had better setups, but they still struggle for reagents to be able to run that machinery. And so very much the treatment of infection was often blind, because they don't have the tools to be able to confirm diagnosis and confirm the pathogens as well. And as Kerry mentioned, sterility of surgical procedures is a big issue as well. We went to a lot of maternity wards and spoke to obstetricians. For caesarean sections, for instance, they carry on antibiotics for a significant period afterwards, but that's because they can't guarantee the theatres are clean. They struggle then with keeping patients clean afterwards, and so the rate of surgical site infections are a big risk there, and so antibiotics are used to mitigate that as well. And as Kerry said, that's part of the whole picture, isn't it, that we need to tackle every element to be able to do this successfully. So, the CW PALMS aims to get more data available about exactly what prescribing is going on, and I had a quick look online. There's very little out there for Malawi at the moment, What I do have is some data from the first stage of the project, so this is unpublished yet, so not for sharing, please. And this is data from 2 of the tertiary referral hospitals that was worked with in the first stage. Nearly half of the inpatients surveyed were on antibiotics. Nearly all of those antibiotics were given IV. Over 90% of those infections were community acquired, which in the UK we would tend to treat with narrow spectrum access type antibiotics, but because of the supply chain, because of the inconsistency within the supply chain, ceftriaxone was by far the most commonly prescribed antibiotic with over 40% of patients. So a very broad spectrum agent, often unnecessary for the type of infection, but very much guided by the supply issues. And that is not without consequence. So this is published data from another one of the tertiary hospitals we're working with in Blantyre, down south in Malawi. It's a bigger data set than Kerry had there, but you can still see that in Klebsiella, the ceftriaxone or third generation cephalosporin resistance rate is scarily high there. And Klebsiella is a very common cause of urinary tract and obviously bloodstream infections here. And with E. coli, the resistance rates are lower, but E. coli is the most common cause of urine blood culture infections. And as Kerry's already articulated, they don't have anywhere to go often with these patients as well. And so the supply issues, the stewardship is having consequences at a patient level as well. I won't touch on this too much because Kerry has done this as well, but really effective stock control going on, and we're hoping to use some of that data to gather consumption data of exactly what's going through the pharmacy and being used as well. And as Kerry said about really effective stock control systems and control on IV antibiotics, they still have issues with medicines being issued without prescription, both in the community and in the hospitals, but they are trying to tackle that already as well. So I'm going to try to link to William's video now. This is where it could all go wrong. So that William can introduce the kind of project to date and future steps as well.
So greetings from the home heart of Africa, Malawi. My name is William Mpude. I'm a pharmacist here in Malawi. I will take you through project overview for the CW PAMS project. So before I go into the CW PAMS 2, let me take you back to CW PAMS 1.5. So the achievements, we had the baseline PPS, we had the AMS list trained on KPI development, an AMS toolkit was developed, AMS lead pharmacists were trained, then cascade trainings by the AMS lead pharmacists, dissemination of awareness videos, and feedback assessment. The CW PAMS 2 project was launched in June 2023. The inaugural meeting was hosted by CPA and FED in Lilongwe, Malawi, with UK partners, Malawi partners, and key stakeholders present. Then visits were undertaken to all new facilities to launch the project with the wider hospital teams, including medical and nurse directors. So here's the map of the warm heart of Africa, Malawi. The northern part, that's where there's Zuzu Central Hospital. The central region is where there's Tambo Central Hospital in Lilongwe. Chinji District Hospital in Chinji. There is a district hospital in Liza, and the Cheu District Hospital in Cheu. The southern part has Zomba Central Hospital and Queen Elizabeth Central Hospital. And as you can see, those are the Malawi and UK partners visiting some of the facilities. So the project will be implemented in 7 sites, as previously alluded to. So the goal is to equip AMS pharmacists with the knowledge and skills to facilitate AMS within their healthcare facility in line with the Malawi National Action Plan, in line with the Malawi government AMR Key Strategy Target 1. So we use a hub and spoke model. The project will intend to leverage knowledge and expertise at the hub hospital to enhance AMS facilities at the spoke hospitals. In our case, the hub hospital is Kamuzu Central Hospital. and the spokes are Cheo, Dedza, and Nkingi district hospitals as they fall within the referral pathway of the Kamusembe Hospital. So we hope that the expertise and the knowledge from Kamusembe Hospital will be transferred to these spoke facilities. So the new developments, we now have more volunteers, close to 50 volunteers, and organized organogram in black and white, accredited to the mentorship by Cymru. Every member now has assigned roles, clear performance indicators, and clear reporting lines. We have a monitoring and evaluation plan in place. We have monthly engagements with the Antimicrobial Resistance Nation Coordinating Center, AMINCC, to ensure that there is sustainability of the project, project activities. We have plans to diversify for a greater impact in the future. So the need project achievements include prioritization of AMS agenda by senior hospital management, establishment of new and strengthening of old or existing AMS committees with AMS action plans in place, antimicrobial consumption data collected and classified into AWARE, the WHO classification from April to September. WPBS done in all sites and spoke and in spoke facilities. It was the first time ever that they had a PPS. Over 50 healthcare workers equipped with the practical skills on conducting PPS. Dissemination of AMS videos. We have TVs mounted in patient waiting areas in the new facilities, in addition to the ones that we previously mounted in the previous project. CW Farms Africa Leadership Fellowship, we have 5 fellows from Malawi. So in pictures, as you can see, the volunteers at Zomba with the management, and the volunteers at Lisa with the management. Now, establishment of new AMS committees. As you can see, at there is a district hospital and in Cheo, and strengthening the existing committee at Queen Elizabeth Central Hospital. Now, there is a district hospital AMS committee developing their annual plans, and in Cheo on the other frame. The problems are GPS data collection by Zuzu, Zomba, Cheo, and Lisa. Handing over of TVs. The first one is Hannah, one of the lead pharmacists here in Malawi, handing over to Zomba. Myself, handing over to Queen Elizabeth Hospital, and Hope, one of the lead pharmacists, also handing over to. So the fellowship, the first cohort had Hannah, myself, and Hope with our respective projects, and the second cohort has Christina and Violet. So upcoming activities include capacity building of over 40,000 members in leadership and management in health, offered by the University of Washington, and this is possible with the financial support from Cymru, and the program will commence on 1 February, 1 April 2024, and it will run up to around June. So training of state healthcare workers in AMS across all 7 facilities, and AMS quarterly meetings. We also intend to undertake the repeat GPS, determine the impact of the various interventions that we are putting in this project. Thank you so much. I'll hand over back to Julie.
So big thank you to William for shooting that for us from Malawi, and for a good overview of the project as well. So I'll just take you back to kind of where we're going, and first of all about the partnership structure, because although we've done the in-country visit, that's just part of the kind of work we've done with them over a number of years now. So as a core team, UK and Malawi, we meet every 2 weeks via Zoom. We've now got a good structure for the project with subgroups formed, as William said, with some of the African fellows taking the lead on those areas to complement their fellowship as well. And as UK partners, we have regular input into all the kind of activities and aspects of the project then as well. And excitingly, the next step is to bring our Malawian partners back here to the UK in June this year. So 4 of them will be coming, and we will be taking them around Welsh hospitals to show them not just all the antimicrobial stewardship activities, microbiology wardrooms, but also how clinical pharmacy operates here as well, for bi-directional learning to see what they can take back then to Malawi to enhance things there as well. As well as the hospitals, we are planning to show them community pharmacy as well. You know, community pharmacy is taking a lead now at being the first protocol in the community for infections, and how that works with independent prescribing and stuff as well. And we're hoping to link them in with the Royal Pharmaceutical Society here, and also the Chief Pharmaceutical Officer to offer that wider support around trying to promote pharmacy within Malawi, and you know, expand their scope, not just for antimicrobial stewardship, but for all clinical elements as well. So other things that we are thinking about going forward is looking to investigate charitable status for the partnership to increase funding revenues. And then for future projects, we're only dealing with a very small number of facilities, hospitals in Malawi, which are just in the public sector. There's lots of scope for the Christian sector, for the private sector, within hospital sites, as well as all the other public ones we're not working with at the moment. But also community pharmacy, as I said, there are still issues with issue of medications without prescription, and so that's another kind of target. And as I said, you know, with the pharmacy kind of profession, it's around what other areas could they focus on as well, oncology, other areas, to enhance things over there as well. I'll leave you with the beautiful African sunset before I finish. Thank you.
Julie and William, thank you very much indeed. So do keep a note of the questions that you want to raise with some of our speakers in the room. We've got one more presentation now, which is Maxentia Nabiro, who is going to be coming to us shortly. I'm happy to answer any questions about the shared learning event. Obviously, we've been making sure that our partners have prepared videos beforehand.
Alex, Julian.
That's it.
The Commonwealth Pharmacists Association, PPA, works to support pharmacists in strengthening healthcare systems across the Commonwealth. As part of our work, we have collaborated with partners to develop tools and resources that facilitate efforts toward addressing antimicrobial resistance in low and middle income countries. Several of our AMR tools and resources have been developed as part of the Commonwealth Partnerships for Antimicrobial Stewardship, CWPAMS program, a planning-funded initiative that is managed by the CPA and the Tropical Health and Education Trust, THED. These resources are developed with input from the CWPAMS health partnerships between the UK and the 8 African countries, and with input from relevant national and global stakeholders. The resources are used continually throughout our programs and updated based on need. We have developed a CWPAMS toolkit. This was designed to enable implementing partners to share learning and experience and provide resources to adapt and use in healthcare institutions. The toolkit outlines MS strategies and projects that healthcare institutions could implement as part of an MS work plan. The toolkit provides examples of MS projects and case studies. The toolkit is a repository of evidence-based resources used by the CWPAM's partnerships to implement the MS projects. We have developed the Prescribing Companion app. One of the key findings of point prevalence surveys and prescription audits is that access to guidelines is a challenge at the points of care. The primary aim of the Prescribing Companion app is to make infection guidelines accessible to the frontline user. The app hosts national prescribing guidelines which can be accessed via a mobile phone or a desktop, while allowing prescribers to access the guidelines and make the most appropriate prescribing decisions for their patients. Once downloaded, the app can be used in areas where there is no network or Wi-Fi connection. We have developed an MS game. This is a game-based MS training tool for groups of healthcare professionals. It encourages players to explore the practicalities of antimicrobial stewardship and the different ways we can all help to reduce AMR. The MS game was designed as a physical and an online game. We have resources on point prevalence survey. These resources are hosted on our website to support our partners in conducting point prevalence surveys on antimicrobial use. One of the common questions we get is about why we advocate for global point prevalence survey tool. So one of these videos covers the similarities and differences between it and the WHO PPS tool. We have IPC resources. Infection prevention and control is very important when it comes to MS and AMR. We have some great IPC resources which have been produced by our CWPAM's partnerships. These range from what IPC is, practical steps to implement programs at healthcare facility, to training videos on how to manufacture alcohol and RAB. We have a CPD platform. The CPS CPD platform hosts modules developed by pharmacists to support pharmacists improve their practice and develop their career. We have modules on AMS, infectious diseases, non-communicable diseases, pharmacy practice, among others. And these can all be accessed via our CPA website. We have developed MS explainer videos. This is a set of 4 videos that were created to support training and creation of awareness on AMR and MS. These short animation videos target the empowerment of both the public and healthcare workers. We have a video defining what MS is, a video illustrating patient experience and advocating for appropriate use of antimicrobials among healthcare seekers. We have a video on continuum of care, showing the journey through the roles of multidisciplinary cadres, and also a video on surgical prophylaxis, teaching best practices for managing surgical site infection. The videos are recorded in 8 different accents from Africa. We have MS Action webinar series that were recorded between October and November 2022 as part of the World Awareness Antimicrobial Week, which we developed in collaboration with our estimated colleagues at the International Pharmaceutical Federation, FIP. These videos feature successes and good practices in MS from across the globe. We have produced several publications to disseminate and share our experiences on MS, and this can be found via our CPA website. These and many other tools that we've developed can be accessible via our CPA website. And in case of any inquiries, suggestions, please do not hesitate to reach out to the CPA. Thank you.
Max, thank you very much indeed. We've been avidly tweeting here at the front, so if I've got your Twitter handle, that's great. And if you want to pass that to me later, that's great. We'll make sure we pass that around. So obviously we've got a number of speakers here in the room. So I just wanted to check in and see who's got some questions that you may want to direct to people who've been presenting this morning. I think we're going to push lunch back a little bit, so there's time for questions. So,
mine's a general question, really. Disclosure of interest here. I'm a public health behaviour change background, and I'm an honorary lecturer at College of Medicine, now Coonhurst in Blantyre. From looking at AMR as a problem in Malawi, I'm just wondering about the supply chain, because whenever I go into Queens, there's no antibiotics. Whenever I go into rural clinics, there's no antibiotics. So if the resistance is happening, is this from oversupply? I doubt it. Overuse? I doubt it. But is it inappropriate use, or is it, non-compliance with adherence to the full regime? I just struggle to understand why there is resistance in Malawi when there is actually relatively few antibiotics available for people to use in Malawi in general.
Yeah, no, it's fine. So it's fantastic to have some moving careers in the room. I'm definitely speaking later. But no, I would say of all the sites that we visited, Queens probably has the best supply chain, which puts that into kind of context. There will definitely be an element of it that is driven by use, and the counteractive resistance there certainly is, because when we go onto the water, that's what we see. But as I said, the main driver in a relatively recent paper for resistance in sub-Saharan Africa is water access to sanitation and hygiene. So that is the main driver of AMR, not antimicrobial abuse, but obviously antimicrobial use still has its part to play, which is why we still need to work on it.
So the selection pressure is a big part of it as well.
Sorry, can you speak up?
Sorry, the selection pressure is obviously one element as well. When they're focusing on one antibiotic for most of their patients, then that will drive resistance in that way as well. And I think the inconsistency is a lot of antibiotics come from a central store, but then hospitals can procure from other areas as well. And some hospitals have a better facility of doing that than others. And so there is disparity across the whole system really about what they can achieve. I think something that struck me was that because they don't know what's in the pharmacy on the ward, that again drives it, because they will will prescribe Petrax, and they know that's the one that's usually there. But when we visited some of these pharmacies, they may have had a lot of amoxicillin in some pharmacies and not others. And it's around how you get that communicated out, you know, in an area that doesn't have any digital stuff on the walls at all, in an effective and timely manner to be able to tell prescribers, yes, you can now prescribe amoxicillin for these patients. So.
Is there any evidence of the ratio between how many drugs, antibiotic drugs, come into the country per user, so that we could get some kind of level and balance to know how much is being used in the country?
There is, I think Julie mentioned the Spark project, which runs alongside it. And the Spark project has a number of different kind of prongs to it, but one of them is supply chain, and that's a new prong that's been out within the last year or so that is being trialled in Malawi in particular, because we raised, you know, there was a limit as to how much you can actually do on the ground if your supply chain's not right, and you know that is a key driver that needs to be addressed at a national level. So one of the pharmacists that we actually, the first pharmacist that we met as part of the sort of matching process, is actually now working for the Commonwealth Pharmacists Association. He's actually undertaken that process. So that's quite good that we've got pharmacists working on that in the country. But at the moment, we don't have that. To put it into context, we have some of those conversations in a UK level, and we still don't know what we don't know in a UK perspective. So I think kind of like putting that into play in Malawi is even more complex, unfortunately.
I'd say well done for the work that you're doing. It's fantastic. Just before we come to our next question, just in terms of visually, so we'll just do a couple of straw polls here, and if there's a few items that fit you, then that's fine. So can I just ask, as a hands up, who currently works for a health board in Wales at the moment? Hands up. Okay, so just help you identify who people you may want to connect with and talk with at lunchtime. Who here is currently part of a health partnership and links with a partner abroad? Who is fairly new to the topic today? Okay, and who is a student currently studying within the room? Okay. Anyone working for Public Health Wales? And anyone working for a NGO? People working in a university setting? And I've probably left a few out, so please feel free to shout out a category that I have yet omitted. Okay, right. Was there a question coming up over here? Yes, please.
Hi, I'm Owen Powell. I'm a GP, also working in secondary care locally, involved with Care in Uganda. I just wonder if you've got any handle at all, or it's going to have any handle, because all of this has been secondary care. And I appreciate that we much more limited data, but what's going on in the community, because we're certainly aware in Uganda, some community antibiotics are prescribed and dispensed directly from health centres. Others, they write a prescription which is taken to the community pharmacy, and clearly in Africa as well as to a bigger extent in Asia, antibiotics are just bought over the counter from private facilities. So I don't know how you get a handle on that, but I'm just interested to know if there's any sort of work at a higher level to try and do that.
I don't think there's anything yet in Malawi, because it is still very, very, very early days in terms of the profession. Obviously, we've taken secondary care as a bit of kind of like low-hanging fruit, if you like.
Sorry, can you speak up?
We've taken secondary care as kind of low-hanging fruit because it is easier to implement AMS in those sort of structures. But I think it's going to be very complex. Generally, it's felt that stewardship in community pharmacies is quite good, but there was a BBC expose at which somebody from the Ministry of Health with responsibility for resistance then found out that somebody had bought meropenem over the counter. So there are definitely issues to be addressed, which we're hoping to look at in a future project, but the complexity, as you say, is
quite a lot of antibiotics being dispensed through government-led programs for integrated case management in the under fives. On there, amoxicillin is the bacteria, but antimicrobials as well. That must be resistant to those things as well. Non-clinicians.
You would have thought so, but we do at the moment. We don't know what we're doing.
Okay, so my question was to Julie. Okay. So, in regards to Nigeria, I want to ask, like one of the challenges stated here is the lack and inadequate knowledge that is actually out there. I want to know how well rather, have you tried to, or with the counterpart, the partners you have there, how well have you tried to bridge the gap in terms of making pharmacists, like in Malawi, I think the pharmacists are doing well, they are doing their best, but there's a gap between the pharmacists, the medical doctors, and the microbiologists in terms of tackling EMR. How well have they done so much to tackle this?
So you are right. What was reported to us as the situation in Nigeria was that the pharmacists are not really that involved in terms of antimicrobial resistance and stewardship. It's pretty much all with the clinical microbiologists. We stipulated that for our webinar series, we would like every represented hospital to send a multidisciplinary team I mean, it was online, right? But to register a multidisciplinary team to the webinar. So we said we would like a representative from pharmacy, one from nursing, and one from microbiology from each hospital to register. We also, but I think that most of the people who ended up actually attending were microbiologists. We also tried to ask our Nigerian colleagues to find pharmacist expert speakers to contribute to the webinars, but again, all the speakers, I believe they were all medical doctors and mainly microbiologists, because they just didn't have the sort of equivalent to our antimicrobial pharmacists. So that is something that is just not the model at the moment in Nigeria. It's all sits with the microbiologists pretty much, yeah. And which is what we tried to address by saying, please can you register multidisciplinary teams from each. I mean, I didn't go into the detail of how we set it all up, but we did ask for multidisciplinary teams from each setting, but I don't think that we got that. So you're right.
Thank you. Question from Catherine.
Yeah, following on from the previous questions, I think, which is one thing that I've seen in our partnership in Lesotho is that there is a much greater emphasis on community sensitisation or training of the public, reaching out to the public, awareness raising across many issues. So I just wondered whether you'd picked up in what you were doing around what's going on in terms of the public demand for antibiotics, because if you've got such a high death rate from infectious diseases, it's very scary, isn't it, that your child could die of pneumonia like that. In this country, I know you as the GP, I'm from a GP background, we've spent an awful lot of time trying to do that education in all sorts of different ways. So my question is, do you think that that some of your partner countries are actually better at doing that community awareness raising? And have you seen any examples of where they've used that for using medicines wisely?
I'm not aware of work that's been done within Malawi, but speaking to our partners, a lot of the messages that came through was the issues are more around people seeking antimicrobials through street vendors, so therefore caused by medicines, etc. Or just even kind of like antibiotic sparing strategies in witch doctors, etc.
Sorry, can you speak back up?
We're talking about not so much access to or kind of demand for antibiotics, but alternatives. So such as kind of using witch doctors or using street vendors to buy falsified medicines. We haven't heard that it is a huge issue in terms of demand, but I would expect it probably is, because I think it is global, isn't it? You know, antibiotics are breakthrough with their own success.
I think some of the discussion out there as well, a lot of the public don't know that antibiotics are antibiotics, it's medicine, but they do, and there's not that awareness of, you know, that being a higher level of information around it, and so there is a big need for all of that, really. And TV will start, doesn't it?
Got three areas. The first one, I don't know whether or not it's been covered or will be covered, because we just look within the silo of what's done within hospitals, within primary care, and missing out surely one of the biggest contributing factors, at least in the Western world. I don't know how relevant it is, prevalent it is in the continent of Africa. That's the prophylactic use of antibiotics in farming. I mean, farming practice is basically done in so many antibiotics. And not just in that, of course, in some countries, I think the USA, as growth promoters. So I don't know how prevalent it is, and don't we need to get an outright ban on the use at all? Not even for sick animals. No way. You know, these animals are never going to be slaughtered and then put into the food system anyway. We just have to let these animals die. It's a clear message: no use whatsoever of antibiotics. A clear ban, preferably coming from the WHO. Wouldn't that be the way to go? At least to save what's left, although that's precious little. That was that's one question. The other, it was made clear with regard to Malawi, we don't know what the people have got. What's the nature of the ailment? So we'll just give them some antibiotics anyway. Or just the situation regarding cleanliness. Well, okay, it costs money, but it's in the interest of the Western world for antimicrobial resistance, not surely to spread. And it's one world. What happens in the African continent will eventually come over. So it would be relatively much cheaper to provide the equipment which will enable hospitals to determine what the person has in the first place, and to make sure that there's sufficient aid to get people over who need to be able to cooperate, to make sure that there's proper sterile conditions in the hospitals, so that it won't be again the use of antibiotics. It's surely, you know, an easy thing to understand and to achieve. I would have thought it's a no-brainer. That's the third question with regard to primary care. With regard to, and I don't know that it's particularly great in the UK, with regard to actually telling patients this is what you're taking, these are the side effects. You know, if you get them seriously, stop immediately, otherwise you must have the whole thing. It's not spoken, not in my experience at all. So we don't have it right here. How are we going to be able to get it right in other countries? Because we need to be able to have a sea change. I mean, is anything like that done? Oh, antibiotics are this, and we must be careful what we use. I mean, surely this is another third area that needs to be. I heard this great thing in this sort of app or something like that in regard to making people be aware of it. But this is just small scale. Surely needs to be done wide scale, retraining of nurses, doctors, etc. You've got to spell it out. Somebody's got to spell it out to people so they know what they should be doing. Either take it properly or don't bother at all. I know 3 different areas to ask about.
Anyone who wants to come in, please carry on.
So, first of all, with regard to farming, has there been any duality of approach in contacting government or whoever NGOs with regard to this situation in Africa?
We are a relatively small player in the scheme of things. You know, we are kind of like, you know, we haven't had huge grants either. But I know that veterinary medicine is in the National Action Plan.
Sorry, can you speak a little bit?
Veterinary medicine is in the National Action Plan in Malawi. You know, they are taking a one health approach, similar to in this country, and I think they are delivering quite well on that as well, I believe. But yeah, it is key, as you say. We all need to kind of like, you know, make sure that we have reductions in our own sector
I add, so in addition, yeah, the national action plan, we will talk later about the experience from Sudan, but Sudan also started to work on the national action plan, and it focused on the One Health approach, including the farms, and also the agriculture, different elements. So there is a willingness to collaborate, but I think it needs lots of effort, and I think there's lots of, they are disaggregated at the moment, but yeah, these are things that are talking about different countries. But yeah, we don't know a lot about how much antimicrobials are used in farming. The system is very weak, so I think this is a very key we need to talk about. Yeah, we need to know the numbers in order to be able to know where the gaps are and how we can change them.
Surely, I imagine in some countries it's not actually anywhere near as big, and so it could be nipped in the bud, especially if there was a worldwide ban through WHO. But I don't think we could achieve that. But if we could achieve, don't start to use it, because this is what's going to happen. Have there been, as you're saying, is there any approaches? You're saying there is some approaches in some countries with regard to this?
Yeah, there are, certainly. And we were at an event on Tuesday where WaAHLN DGC were feeding back what's happening in Wales.
DGC?
WaAHLN DGC, which is the group that implements veterinary AMR and AMS in Wales. They've had some really significant reductions in antimicrobial use, so there could be some bi-directional learning there as well, I think.
In the interests of time and good management, I am going to pause. I'm going to give you some information about lunch first. So please listen and look. Okay, so
can I ask about the primary care thing? It wasn't quite.
Okay, I'm going to ask you to kind of hook up at lunchtime. I think that's the best approach here. Okay, so as you approach the lunch stand, before you start grabbing bags, step back. There, we've been identified a couple of vegans in the room. So please, if you are vegan, do take the vegan bags. We also know, I'm not going to spoil the surprise about what's in your bags. If you don't like what's in your bags, trade, talk, swap. So the vegetarians have cheese and pickle. The meat is a cheese and ham option. Vegans are onion bhajis, and somebody who identified as gluten-free, please make sure that you get the appropriate salad. There are some other nourishments that are in the crates underneath the table. Don't all rush at once, spread out between drinks, fruit, etc. And any issues, please come to me. So as a suggestion, we're a little flexible on the timing. I suggest we have 25 minutes, if that's all right, so we can continue to munch and walk. And we'll start back at 1:15. Would that be all right with people? If that creates a worry for you with trains, then let me know. But we'll start back again here. If you're still eating, that's fine. So 1:15, and help yourselves to lunch and enjoy. Thank you very much.
Readying yourself for your moment of glory. Can you get
that'll be the decision of in there.
Back to that.
The easiest way is just to
I might like to look at your inspiration and close this down, go to the video, and practice some animations.
Okay, are you Emily Dot?
Okay. Go on.
Emily Dot Davies.
Do we have
DAVIES?
that
Number?
one?
13. Do please take a bag, and if you've got to share with a colleague, take one for them. That's fine.
Thank you so much.
So there you go.
Got the hang of it.
It's fairly easy. I haven't got it wrong yet, so it's not that difficult.
Desperation.
Okay. Yep. Yeah, that will all be fine. Very confident. Yeah, you might as well. What's at the other side of that?
Yeah,
it's on the other side of the head.
How do they explain?
So that's not the institution.
Done very well so far. Exactly. Brilliant. Okay, yeah. So that is
particularly important if people,
yeah, it's really typical X whatever is like they kind of, I think they thought we were underage. Something like, oh, you're not of age. It's like, what?
Until someone tells me, I'm not going to give any more.
Pop out to do something that would be befitting and help with it. Cigarette. No, we're more Welsh-based volunteers who can
Yeah, it's taking on more than I should, but I still really keep in touch with me. I've been thinking of maybe forwarding one.
And at the end, if anyone wants to take lunch and have because you're economic, I'll have that. Make sure you get up
Germany has rolled
But no thing is like
no, I haven't even got one yet.
we're on you know, in quite London, so it's pretty in Rossa, how can we have to do all the UK?
It was
I've got this guest lecture. I need to go and substitute for
I've only just got back from a meeting quickly.
Don't forget about our superbug store. Do please come and have conversation.
Yeah, I confirm. Most of which are
yeah, things are moving a bit slowly with it, just because it isn't. Are you there next Tuesday at the celebration event?
most of them lose so it can go into the minority population. There's something about those friendly bacteria, friendly souls that are kind of adapted to household I know how to get
I know, it's traveling. You go on Facebook.
Well, we've got very close
I don't know why.
All online.
I started microbiology private. Wasn't there when I started.
Well, well, I wish I could take credit, but it was Emma really who organised it. She did all the hard work. I was just like rocking us on the day and taking dismissive photos of the lunch. To be like, yeah, lovely. Yeah, they were kind of signed up for mentoring, so it
Julian, we didn't press pause on record, did we?
No.
No, that's fine. Okay, so welcome back, everybody. Please feel free to continue engaging in lunch and snacks. And so we have a few more interesting sessions for you. And again, if people will please introduce themselves, and we'll stop for questions towards the end of the afternoon. Amanda, the floor is yours.
Bryn Dar, good afternoon. Thank you all for staying. It's lovely to see so many people. So I'm going to talk to you about healthcare associated infections, and this really follows on for the morning. We've spoken about antimicrobial resistance, but now I'm going to talk to you about how we reduce healthcare associated infections in the first place. And in order to do that, I'm going to concentrate on infection prevention and control and draw on my experience in Uganda. So last year I was funded through Welsh Government International Learning Opportunity to undertake some work in Uganda. So I'm going to draw from that experience. Just to say, I am a nurse. I work for Public Health Wales, and I'm the lead for infection prevention and control in the community at the Healthcare Associated Infection and Antimicrobial Resistance Prescribing Programme, which is part of Public Health Wales. But also, I've had an interest in working globally since 2006, so I'm going to draw on some of those experiences as well. So when we talk about healthcare associated infections, these are infections that have been acquired by patients when they've been either admitted into hospital or through contact with a healthcare facility. So the infection's not incubating at the time, that's not the reason for their admission, they're actually acquiring it while they have that care delivery. So I think we're very much aware of that given the recent pandemic. So according to the WHO then, at any one time, 7% of patients in high-income countries will experience at least one healthcare associated infection, and that's 15% in lower and middle income countries. And that figure actually increases, that percentage rises when we've got vulnerable populations such as neonates and anyone who requires more intensive treatment, and that's largely because of intravenous devices, catheters. So the more complex the problems, the more at risk somebody becomes of acquiring a healthcare associated infection. And that leads to considerable mortality and morbidity. So we think about the patients who have prolonged stays, the effect on the economy, and their capacity to be able to work and be at home. So how many of you are actually involved in infection prevention and control in one way or the other? Just a hands up. Right, okay. So this picture here of this cow, and that's to demonstrate that infection prevention and control is everybody's business. So when we've just recently come out of the pandemic, we will appreciate how important IP&C was in our households, but in schools, in colleges, in closed settings. So it does affect us all, and it can be very challenging. Now, Kerry has already mentioned about hygiene and sanitary conditions, and everybody should have access to running water and be able to use a toilet, and that's one of the United Nations Sustainable Development Goals. So let's have a look at what that picture looks like in Uganda then, of a population of 47.3 million. Only 92 million don't have clean water close to their home, and 37.3 million don't have a decent toilet of their own. And if we think about what happens when our patients access healthcare facilities, 688 million people globally who access healthcare facilities, they won't have access to basic hand hygiene services, which includes water, soap and water, and alcohol-based hand rubs. So my experience, as I say, in Uganda, I was matched with an organisation called Teams for You, and they run a water and sanitation hygiene programme, and they were able to overhaul the plumbing system in the hospital that I worked in eastern Uganda, and install hand wash basins, as well as in the some of the community healthcare facilities. They were able to install running water through boreholes so that it was much easier for staff and patients and visitors to have access to running water. And that's running water is not just a prerequisite to health, but it also contributes to people's livelihoods. It's important for school attendance, so period health for children, female children, but it also creates very resilient communities. So I'm going to take you on a tour. If some of you have never been to a hospital in a low and middle income countries, I'm going to use some of the sort of pictures to create a sort of guided imagery. So we're going to go on this tour together, which is something I often do. When I go into hospitals, I get the lead IP&C focal person, or just find somebody who is going to be that person to show me around the hospital, so we can work together on identifying of some of the issues. Now the WHO, you can see from the diagram on the right hand side, hopefully, have developed guidelines around what are the core elements of an infection prevention and control programme. And they've identified these 8 elements. So if you see here, we've talked a lot about political will, we've talked about laboratory surveillance, and we've talked about budgets. And all those are absolutely fundamental to an effective IP&C programme. So I'm not going to talk too much about those things, but if you looked at the next layer, we've got guidelines, education and training, which has already been mentioned, surveillance, which I'm going to talk briefly about, and the global prescribing point prevalence survey. But we also need to have the monitoring, audit and feedback to know that our programmes are being effective. And then we need that enabling environment. We need workload, we need staffing. I'm not going to talk about those things. So these are things I'm going to concentrate on very briefly. Is all hospitals, healthcare facilities at national level and at healthcare facility level need to have standard operating procedures and guidelines around these core elements, and around the guidelines, sorry, and that's the hand hygiene, decontamination of equipment, environmental cleaning, waste management, injection safety, protection of staff, so occupational health, aseptic technique, and triage. So that means the patients that present to our hospitals and our healthcare facilities, what are we going to do if somebody presents with a respiratory illness, with a rash, with a fever? So we need to have systems in place to be able to identify those patients and be able to isolate them appropriately. And as I say, I'm also going to touch on surveillance. I mean, unfortunately, in the hospital where I worked, and we've heard this echoed through many of the speakers, that lack of microbiology and laboratory services. The hospital I worked in Uganda, they had the experience, they had the knowledge, they didn't have the funding, they didn't have the assays in order to produce an adequate system of culture and sensitivity. So prescribing was empirical, and this is going to be echoed through much of what the speakers have said previously. Just to emphasise a couple of documents that you may find useful, and that's again a framework by the WHO which states minimum requirements for infection prevention and control programmes. So it's small steps, it's where you can start to identify gaps, and there is access then to WHO portal, which has the tools and resources that are necessary in order to perform an infection prevention and control assessment, and the assessment tool is embedded in that portal. However, this is what we used in Uganda when I was there. So again, at national level, there needs to be some national guidance. So Uganda has national infection prevention and control guidelines. They're a little bit out of date, as you can see. But you can also see that the Ministry of Health there also provide these manual carbon copied booklets where you can then identify where the gaps are. So green is for appropriate intervention in place, yellow is in progress, and red is where the intervention is not in place. So hopefully you can see that okay. So if we look at what we're doing well in the hospital in Uganda, we can see equipment decontamination and environmental cleaning. So hold those thoughts. And what we can see is they're doing less well is there is an incinerator, but there are issues with the incinerator. And this probably won't be that unusual for some of you who have visited hospitals. So one of the positive things was there was an infection prevention and control committee, and there were focal people in infection prevention and control, both in the hospital and also at each healthcare facility level. This is a little bit out of sync, but the animations didn't quite work. So let's have a look at some instruments then, some surgical instruments on the right hand side. Does this look okay to you? Yes, no, so this must have been used post-intervention. So that looks like a catheter that's there sitting on the side, along with surgical instruments. So decontamination is really key here, because you don't want to then use the same instruments which have not been properly decontaminated on another patient. So we're looking at reducing the transmission of infection from one person to another through these procedures. So you need to have these SOPs, you need to have the training in place. People need to understand a dirty to clean flow, a method in order to collect used instruments, to then go through a cleaning process. So all instruments need to be cleaned first. They need to be moist, because otherwise if they're dry and there's blood there, it's much harder then to decontaminate them through sterilisation, which is the choice for surgical instruments. So there needs to be a process of cleaning with soap and water with this equipment to open them up, because you need to remove the organic matter and the proteins in order to be able to sterilise it effectively. I'm glad somebody's nodding their head over there. This is quite often what we see, instruments that have been in contact with mucous membranes, that have been in contact with blood, not submerged, but maybe sitting on a windowsill. So again, it's having those processes in place. Equipment needs to be submerged, because when you're cleaning it, you want to avoid splashes. And also there's a whole mixture there of different pieces of equipment, just have a different contact with body parts. This was in the treatment room within one of the healthcare facilities where they performed male circumcisions. So there's this equipment used afterwards on the trolley and next to lots of other items that can get contaminated. If you look at the back, you can see there's a little label that says JIC. And JIC is a brand of bleach that is used in lots of used throughout Uganda. So often this disinfectant is used either to decontaminate equipment and not sterilise it, or it's left soaking in bleach. Now bleach, as you probably will know, will damage your equipment, and it's not effective at cleaning. You need to really, it's the mechanical process that's removing some of the proteins on organic material. Does anyone know what this is in the corner on the right hand side? Yes? It's a pressure cooker, which is a mini autoclave really. So quite often this is used. You might not want to use this one, it's not very clean. The area surrounding it's not very clean. So even if you have access to a pressure cooker, you need to make sure it's maintained and that it's clean. And so this is myself and Martin at the end talking to some of the theatre staff about some of these pictures and looking at how we could improve services together. So if you remember, we're going back into the hospital now, and within the hospital they were undertaking a number of surgeries, which included gynecological surgery, some abdominal surgery, and they've got a nice autoclave, which you can see one of the nurses is demonstrating. Now there has to be procedures in place when you're using autoclaves, and obviously you need water and you need power as well, and you need staff that are trained, because once those instruments are removed from the surgery, you need, as I say, a process from dirty to clean. So you need to clean those items, you need to pack them, and then they will then go into the autoclave for steam sterilisation, which is the majority of methods that are used in LMICs. So what you can do also is, this is an indicator which goes inside the packs before you autoclave, and these are indicator strips which will show you that the equipment inside has reached a sufficient temperature in order to kill the microorganisms. I've just put their SPECT. I don't know if any of you have ever come across SPECT. They're a charitable organisation, and they do lots of training in country around sterilisation and the process of it. You do need to have trained staff in order to make sure that process is safe. And I'll just also signpost you to a couple of documents, again by the WHO, around decontamination of equipment, and also to look at preventing surgical site infections. So I could talk a lot more, believe it or not, about this subject, but we haven't got a lot of time, and there's a few things I'd like to cover as well. So this is a question for you. So what percentage of healthcare waste is infectious healthcare waste? So what do I mean by infectious healthcare waste? Is it's waste from a person who has an infection. Okay, so it could be bandages, it could be gauze swabs, something allied to that, infectious healthcare waste. So we're going to do a very technical poll. I'm going to ask you to raise your hands if you think, is it 10% of healthcare waste that's infectious? Okay, there's some good few answers. 50%? Okay, so probably a lot more of you have said 50% and 85%. Yes, thank you very much. That's one person at the back. Right, the answer is 10%. So if we think this is not an uncommon picture that some of you have probably seen, particularly in the hospital environment, of a lot of waste all thrown together, but only 10% of it is actually infectious. So you think there's a huge amount of scope for that 85–90% of waste that is comparable to domestic waste. So there's an opportunity there to look at recycling, to look at energy recovery, to look at composting. But sadly, in a lot of LMICs, we find the two main methods are burying and incineration. But there is a lot of scope. Unfortunately, there's not always access to some of the newer technologies around sterilisation, about energy recovery, so making that waste into fuel that can then be used, or it goes into the building industry. So it's all recyclable, it's all used. So we now need to, as we all know, to think about the sustainability elements and the potential for contamination of water when we bury waste, and the leachate that comes out of those of that particular waste. So again, this is not uncommon, and Kerry and Julie have shown pictures from their experience about the huge amount of glass vials that are used. What do we think about this? Who's at risk? Needles, syringes in boxes, and that has to be transported from the ward area and the hospital to some storage area before it's either incinerated or it's disposed of through an external contractor. Waste, sharps bins. Sharps is a massive problem, as we can see. Enough sharps bins. This is completely overfull, and you think about the risks to the healthcare workers, to others who are handling it. And this is not uncommon to find it strewed through the hospital grounds. So we've got animals at risk, we've got people at risk, waste pickers, scavengers, all sorts of people who are at risk from bloodborne viruses through contaminated needles. And this also, remember we saw the hospital as an incinerator. Well, incinerators have to reach at least 200 degrees, and then all it's doing is reducing the volume. But then you've got ash, but you've also got these glass vials, you've got needles where they've been incompletely incinerated. Then you have to deal with this, plus all the toxic fumes that come out of burning, incinerating, out of combustibles. You've got the dioxins and the furans, which are causing a hazard to the environment. And are these injections necessary? So quite often, everybody, the expectation of patients is sometimes, I'm going to hospital, I'd like an intravenous infusion, or I want a cannula. And if they don't get it in the government hospital, they're going to go and get it privately. So why are we using so much intravenous medication, not just antibiotics, but lots of other uses of intravenous methods of giving medication? So I'm going to signpost you again to this document, which is a safe management of waste for healthcare facilities. And it's packed with really useful information about waste minimisation and how, if there isn't a national policy around waste management, how you develop that in a very systematic way. How you segregate your waste, as we can see that's really important, how you store your waste and how you then dispose of it. Right, this is another question for you. What are the main routes of transmission of harmful microorganisms? So that the main three, bacteria, fungi and viruses. So the options are, is the main route contact with blood and body fluids? Is it contact with the contaminated environment? Is it sneezing and coughing? Or is it all of the above? You can just shout out if you want. What do you think? Don't be shy now. All of them. Does everybody agree with that? Yes. So it's all of those are the main routes of transmission of harmful organisms. And how does that work? Well, we've got our patient who arrives at the hospital or the healthcare facility with an infection. They then may contaminate the equipment and the patient and the surroundings around them. Healthcare worker goes in, hands become contaminated through that contact, through the contact with the environment, and then that's passed on to themselves through contact with their own mucous membranes, mouth, eyes, nose, and then on to susceptible patients. So we now know there's an enormous amount of evidence around the importance of a contaminated environment and how that contributes to transmission of infection. So cleaning is really key. And again, I'm signposting you to a couple of documents and lots of training that's available through this portal by the World Health Organization. And we really need to value people who clean. It's really key that they're paid appropriately, but also they're given the value that is warranted for the importance of reducing healthcare-associated infections through contaminated environments. So this gives you a very comprehensive program of how you should clean and what you should clean with. And you don't need expensive resources, soap and water, and just identifying how you clean are key elements of a clean environment. Just very briefly then, to talk about hand hygiene. We know it's an enormous challenge if you don't have running water, but it's an even greater challenge if you don't have soap. And of course, drying is another matter. People are often will do everything right, and then to dry your hands, you sort of just tend to wipe it in your uniforms or your clothing, and hence you start the contamination of your hands again. But as I say, in the hospital, we're very lucky to have soap and water. And this is running a workshop with midwives, with students, with hospital staff to look at hand hygiene. And some of you might be familiar with using the UV light to demonstrate hand hygiene technique. So you use a glow gel, you apply the glow gel, you wash your hands, and then you can compete with each other to whoever has performed hand hygiene most effectively by then demonstrating under the UV light. So you can see here the obvious parts of the hands which are often forgotten, so re-emphasising the importance of hand hygiene technique and having hand washing champions and ambassadors. Now this resonates with everybody because we have the same challenges everywhere, and hand hygiene is one of those particular challenges. And going back to what Kerry was saying about behavioural change, it is very, very complex. It's not so easy as just telling people to wash their hands. They really need to see the value of doing it. So I'm going to talk about surveillance and some of the work that I did collaboratively with a team based at the hospital in Uganda. And as I said, they have an infection prevention and control committee, and that's supported by the medical superintendent and also the district health officer. So people with power and influence around the table, although this starts off with a few of us around the table, as you know. As the time goes on, the number of people increases around that room. So this is us agreeing that we would look to trying to establish what is the burden of infection in the hospital, what kind of prescribing is there. We've got no laboratory surveillance, everything is empirical, everything is based on clinical symptoms. So we really wanted to get a sense of that, and I looked to my pharmacy colleagues who suggested getting in touch and accessing the global prescribing point prevalence survey, which is what we did. So it's very simple to register. So we registered with the medical records person, who I stalked for a number of days before he agreed. And this is some of the nurses, so it's always best that you get the team involved in having to look through the notes. It's a very long process, so it's good to have people in place who know how the hospital works, because you don't want to be too intrusive around ward rounds and also patients undergoing various procedures. There are Ugandan clinical guidelines, and they have the first line antimicrobials for the most common conditions. So I'm now going to try and play a video to you, this is Ines Powles, who's from the University of Antwerp. She's part of the coordination team at the global PPS, who I probably irritated for the 8 weeks that I was in Uganda, but she gave lots of advice and lots of support, and the support is there at various intervals. If you want to undertake this, it's extremely straightforward. So I'll show you some of the results in a moment. And just go into the videos, bear with me. So this is about 11 minutes long. So I'm just going to play that for you now.
Hello everyone, my name is Ines Powles and I'm a doctoral researcher at the University of Antwerp and a member of the Global PPS Coordination Team. And today it's my pleasure to introduce you to the Global Point Prevalence Survey of Antimicrobial Consumption and Resistance Project, or simply Global PPS. So first I want to talk a bit about what is a Point Prevalence Survey, or PPS. According to the CDC definition, it is a collection of data used to identify the number of people with a disease or a condition at a specific point in time. So essentially, point prevalence is a cross-sectional snapshot of data used to determine the number of individuals with a particular condition at a very specific moment in time. And so unlike incidence, which tracks the number of new cases over time, prevalence focuses on existing cases within a population at a given point. And so in our context, we are particularly interested in conducting point prevalence surveys on antimicrobial prescribing in healthcare settings. So imagine you want to conduct a point prevalence survey on antimicrobial prescribing in your hospital or in your healthcare institution. This would be how it goes typically. At 8 a.m. on a designated day, we assess how many patients are present on the ward where we are conducting our PPS, and then we count how many of them are on antimicrobials at that time. And then for all the patients on antimicrobials, we are going to collect some additional information, such as the patient characteristics, the name of the antimicrobial, the dose, the route, and the frequency, the diagnosis for the antimicrobial, and the type of indication, by which we mean, was it healthcare associated, was it community acquired, was it empiric or targeted treatment, has a clear stop or review date been documented in the notes, has a reason for the prescription been documented, was the prescription written according to the guidelines, and so on. And so all of this information can give us a comprehensive understanding of the quality of the antimicrobial prescriptions within our institution. Now, why should we want to conduct point prevalence surveys on antimicrobial prescribing? Well, they can be really useful tools for guiding antimicrobial stewardship efforts. So firstly, you gain insight into your institution's antimicrobial prescribing patterns, which allows you to identify potential areas for quality improvement. Next, once you have developed your antimicrobial stewardship activities or interventions, you can use repeated PPS measurements to measure the effectiveness of your interventions. And then finally, just by conducting a PPS in your institution, you're already going to create certain awareness on appropriate antimicrobial prescribing in your hospital among the healthcare practitioners. And so therefore, it's really important to really actively communicate the PPS results in your institution and to also involve the prescribers, the nurses, the pharmacists, and even the management in the discussion. Now let's talk about global PPS. What is it and how does it fit with all of this? So global PPS is a collaborative project with a network of hospitals and healthcare institutions worldwide that are conducting point prevalence surveys on antimicrobial use. And so the project started in 2014 and is coordinated at the University of Antwerp in Belgium. And global PPS offers a standardized methodology for surveying antimicrobial use in both inpatients and outpatients, and any hospital or healthcare institution worldwide is welcome to participate. So the most important principles of global PPS data collection then, global PPS offers separate modules for inpatients and for outpatients. Now, in general, these modules are quite similar, but they are each tailored to their own unique care context. And so the inpatient global PPS can be conducted in hospital inpatient departments. You include all hospitalized patients occupying a bed at 8 a.m. on the day of the PPS. And then you're going to collect detailed information only for the patients on antimicrobials. For the global PPS for outpatients, this can be conducted in hospital outpatient departments, such as the emergency care ward, in outpatient clinics, or in community healthcare centers. And here you include all the patients seen on consultation for a minimum of 4 hours on the day of the PPS. And so in contrast with the inpatient PPS, you are going to collect demographics and symptoms for all the patients you have seen during this period. And then you're going to collect more detailed information only for the patients on antimicrobials. And so all the materials, the protocols, and the data collection templates for both inpatient and outpatient global PPS are available in different languages on the Global PPS website for any participating institution. Now, to facilitate data entry, we've developed a user-friendly online platform that is accessible to all participating institutions, and you can reach it by going to the Global PPS homepage, and then you can click Read More below Data Entry, which will take you to the platform. Or you can go directly using this URL. And so the platform has several built-in quality checks and an automatic validation procedure to ensure the consistency and the quality of the submitted data. And it's possible to enter your data directly into the system or after you've collected the data first on paper. We have a set of training materials and tutorials available to help users throughout this process as well. And then another important feature of Global PPS is that it generates personalized reports for the institutions that have collected PPS data. And so this is in the form of a PDF that contains a set of graphs and tables reporting the results of the PPS. And so a few examples of what these reports look like are shown here on the slide. And as you can see, these reports are ready to be used for local communication. They also include benchmarking data, so the hospitals can compare their results with country level and regional PPS results. The reports are generated automatically and immediately after data entry. So that means that there is no need for the institution to analyze the data themselves or to wait until the analyses are done. Another feature, of which you can see an example here, is the online interactive feedback report, which allows you to customize your results according to your area of interest, and also to have an idea of the evolution of your PPS results over time if you have participated multiple times. Important to note here also is that the need for ethical approval to conduct a point prevalence survey on antimicrobial use depends on the country and the setting. So in some countries it's needed, in other countries it's not. The data are safely stored on a secured server at the University of Antwerp, but the institution always remains owner of their own database. And also, very importantly, PPS results are strictly confidential and are never shared without explicit written approval from the institution, leaving the institution always in control of their own data. So, to summarize, global PPS is a common and standardized methodology which allows you to collect valid and comparable antimicrobial prescribing data. The protocol is relatively simple, with the aim to offer a feasible way of collecting data. There's the aspect of quality assurance using the online data entry platform. The automatically generated feedback reports allow you to quickly and effectively communicate PPS results in your institution and start working on antimicrobial stewardship. And finally, there's a central support in the form of a help desk, trainings that we give, and manuals and study materials in different languages. And with that, I would like to conclude this introduction to global PPS. Thank you so much for your attention. You can find all study materials on our website. And should you have any questions, you can always reach us via email. I wish you a great day ahead. Goodbye.
So thank you there to Ines for explaining about the global PPS. I'll just go to, have I got 5 minutes just to, 2 minutes? Okay. 2 minutes then. Where are the... Just trying to find my...
If you go down to the bottom,
oh yes, yes, got it. Right, just 2 minutes, just to briefly, this is really just to show you what it looks like. So you put in your data, and then as Ines explained, they are able to put the graphs and the data into graphs, as I said, and to other diagrams for you. So just very briefly, the overall prescribing...
Just big screen, please.
Oh, sorry.
So that's it. Thank you.
Apologies.
Thank you.
So overall, a prescribing rate was 71.2%, and this is the kind of comparisons that's made with other countries, which, you know, comparing it to high-income countries is not necessarily very valuable. But if you look to data that's already been conducted, so these were point prevalence surveys in neighbouring countries, 71% in the hospital that I worked in compared to other neighbouring countries was much higher, so the average was about 50%. And then this shows you around specific indicators, so the reason, the indication for the use of the antimicrobial. So the medical notes, you can see that was around 61.9%, guidance compliance was 52.6%. So we're able to look at the prescribing and then check the Ugandan clinical guidelines for whether that was compliant. We were also able to look at case studies. So if you look on the left, this is the medical notes. This was a baby. It just says baby, 4 days old. Continue ampicillin, gentamicin. That's all the entry that was. There was no indication for use. So you can see how valuable it is when you start to interrogate the notes. On the right-hand side, we have the notes of a pregnant lady. I don't know if you can see that. She's got malaria, but she's got cystitis. I asked my pharmacy colleagues, what is first-line antibiotic for cystitis? And it's not ceftriaxone IV. So we've already heard the high use of ceftriaxone in some of the countries already mentioned, and there is a very high use of ceftriaxone across Uganda, as well as non-compliance to the guidance for a number of reasons. Briefly, we've already mentioned about surgical site prophylaxis. So on the top bar, you can see that in those 28 patients, 94% of them were on antibiotics for more than 1 day, which is against the Ugandan clinical guidance. What did we do? What happened when I left was I kept in touch. We'd suggested an antimicrobial stewardship committee. They looked at restricting antimicrobial use for minor illnesses. They'd looked at wider dissemination, including the app for the Ugandan clinical guidelines, auditing, giving feedback, and continuing that development of diagnostics. I just want to very briefly draw your attention to the Infection Prevention Society. We have an annual conference, international conference, that will be in Birmingham. If you are working in a low and middle income country, there are special access fees for you. You can also join and have special access membership. So I'm just going to leave you with this slide. So I'll let you quickly read this. This was a menu that I found at a restaurant that I was in Uganda. So this is our national food in Great Britain. British food is usually quite plain and simple, with few spices or herbs. Potatoes and bread are the main staples. Traditional British dinner consists of meat and potatoes. Blah blah blah. You can read that at your leisure. Most of you will be familiar with the national dish of fish and chips. And what really my point to make about this is, bi-directional learning is really important. But we have a lot to learn from our colleagues in low and middle income countries. They are resourceful. You don't need technology. Sometimes you just need a different perspective. But our colleagues are used to working in a low resource setting, and they are very resourceful, and we could learn a lot from them, particularly around fish and chips. So all I want to do in that 2 minutes, which is probably overrun, is just to say thank you to all my colleagues in Atito Hospital in Cymru district, and all the colleagues in the healthcare facilities. And thank you all for listening. Thank you.
Amanda and Ines, thank you very much indeed. So we'll just please continue to scribble questions down. Okay, I'm delighted to introduce Isra, who will tell us a bit more about her role and her work.
Hi everyone, I'm Isra Mohammed. I'm epidemiological scientist at Public Health Wales and the Heartfield Healthcare Associated Infections and Antimicrobial Prescribing Program. But previously I worked as a pharmacist and clinical pharmacist in Sudan. So I'll be reflecting on my pharmacy experience, and I'll put my epidemiology hat away this afternoon. So given a bit of a background, starting with numbers, we always think we need to know the numbers before talking about what intervention that we need to address or what we need to do. So AMR death in Sudan is higher than neoplasm and non-communicable diseases and even respiratory infections. So it's one of the major causes of death in Sudan, according to health data. There. So I worked as inpatient and outpatient pharmacist in Sudan from 2014 after my graduation to 2019. So initially I worked as a community pharmacist for 3 months, and this was sufficient to repel me from working in community pharmacists, mainly because of dispensing policies. The public are very I think there was a lot of pressure in getting prescriptions. Even if I refuse to give them antibiotics, they will go to other pharmacy and they buy it, and sometimes they come and show me that I got it from the other pharmacy. So I was a fresh graduate and there was not much to do. So I decided to shift to hospital pharmacist. I worked there for a few years, and in the hospitals there are stricter policies, mainly because of reputation issues. It's not because they want to be strict with AMS. It's because they want to be to attract more patients, because most of the good hospitals are private hospitals, and I worked in a private hospital in Sudan. So they wanted their medication to be kept for the patients, so that they can have more patients coming up to the hospital. Just to give a bit of context, the pharmaceutical sector in Sudan, similar to many African countries, is private, and out-of-pocket payment is huge, contributing to more than 70%. So if you are ill, if you have any illness, you have to go to the doctor, you have to pay for the doctor, you have to pay for the lab, and then you have to pay for the medicines. So it's easier just to pay for one thing than to pay for three things. And this is why the public prefer to go to pharmacies and buy medicines. So I think this is important to understand why one of the drivers why people prefer to buy antibiotics and not go to hospitals or contact the lab team. So in the next couple of slides, I will give some examples from myself and my medical colleagues of quite concerning cases that we encountered in Sudan. So this is a lab result from a patient with Pseudomonas aeruginosa infection, written in Arabic here, but it's resistant to all antibiotics, including colistin and meropenem. So this patient left with nothing to be administered to him, and I think the medical team just didn't know what to do. I think they left just hopeless, nothing to do for this patient other than to wait until he dies. The next example is a lady that had a Staph aureus isolated in wound swab after a cesarean section. So you can see that she had Staph aureus resistant to most antibiotics and sensitive to two antibiotics, linezolid and roxithromycin. So if you can see here in this lab result, it's written University of Jazeera, and Jazeera state is outside Khartoum. It's one of the cities outside Khartoum, and the health facilities and the health provision is better in the capital, Khartoum. Jazeera state is slightly better than other states or cities in Sudan, but the cost and the availability of the two sensitive antibiotics is almost impossible in the Jazeera state. So I remember when I used to work in one of the big hospitals that we had most of medications available. Linezolid and roxithromycin weren't there when I was working, so I'm not sure if this patient ended up finding a relative elsewhere outside the capital or outside Sudan and who was able to provide them with this one, or they ended up just dying because of resistance to most available antibiotics. This is a third example. This is a very personal example, and this is when AMR started to be very personal to me. So I had a relative, that was in 2017. I had a relative, more precisely my uncle, my dad's brother. He used to live in the west of Sudan, in Kordofan, and the healthcare facilities are quite bad in Kordofan, and he had tuberculosis. So TB medications are free of charge. You get them through NGOs and Ministry of Health, but you have to have your file and you have to go to a specific facility to access them. Unfortunately, there are always problems with medication supply, and I think we talked a lot about the supply of medications. So he ran out of TB medications many times, so he had interrupted TB medications, and he developed resistance to almost all TB medications, and he had extensively resistant TB. And he sadly died. He sadly died because of the AMR, and I wasn't able to help. I was in a different city, and I was a pharmacist, but I wasn't able to provide him with anything because it has to be accessed through certain routes, and maybe this is one of the reasons why I decided to shift into public health, because I felt I'm a pharmacist, but I wasn't able to help one of my very beloved relatives. Shortly after that, I decided to start doing some health education things. So I contacted a few colleagues, and I was invited to talk in a local radio about the irrational use of medicines and give a more focus on antibiotics. And it was live streamed episodes, and it was fantastic. The engagement was really good, and we had few calls from those outside the capital. So that was really very impactful. And I received another invitation to have more episodes in another radio program. So the public perception of it was really good, and even in the Facebook page we received lots of questions afterwards. The 3 magic tabs for flu, it's very common in Sudan, azithromycin. So people generally think that if you have flu, you can take azithromycin, and it's composed of 3 tablets, 500 milligram. So if you take the 3 tablets, you will be fine. So it's the public perception of this antibacterial that it will cure your flu, that is mostly viral, is widespread in Sudan. So I talked a lot about that. The 3 tabs are not magic tabs, and they are for certain infections. And it was really helpful. And yeah, the public are quite keen to learn. I think they weren't resistant, but I think they received it very well. And after that, shortly, I think 2 years after, I had one of my colleagues who created a Facebook page called "The 3 Tabs Are Not Magic Tabs," and starting to increase the awareness of the 3 magic tabs. That please don't take them. So this is something that I worked on a country level. In July 2017, Sudan adopted a national action plan for AMR, following also, I think, Malawi and few African countries were also developed the similar approach. And Sudan was one of the first African countries, actually, to address this issue and to draft this document, and focused on collaboration between WHO, Ministry of Health, Forestry, and also Animal Resources and Fisheries. So a multi-agency approach to address AMR and trying to find ways to fight the what we call the silent pandemic. Talking about challenges, I think most of challenges are, we talked about them earlier, behavioral change or the surveillance. If we don't know the numbers, we will not be able to understand the impact or how widespread it is, and also the improving awareness and hygiene, as Amanda talked about it. The coordination between institutes, we have lots of institutes, but everyone is working on themselves. I think this is something that we really need to work on, and the selection pressure. I think we briefly talked about it. So also something that still happening, that the medics or physicians or clinical pharmacists, when they prescribe medications or antibiotics, they take into account the availability factor. So if you have a minor infection that can be treated with narrow spectrum antibiotic, but you don't have it in the city, or we don't have it in the pharmacy, you want to cure the infection, what you're going to do, you're going to prescribe broad spectrum antibiotics. And this is something that is widespread in Sudan. So there is lots of selection pressure on that part. So what is slightly different, or different from maybe the other countries that's being discussed earlier, the war in Sudan that started last year in April 2023. So this worsened the situation more. So where next? What happened since April 2023? Collapsing health system. The health system is almost collapsing, and colleagues in the country noticed increase in war-related infections, including the gram-negative infections, and we know how contagious they are. Post-traumatic osteomyelitis is very seems to be very common now, and it's not surprising in war-affected areas, mainly involving Enterobacteriaceae resisting to first-line antibiotics. So these are very concerning, and many others. Why it matters? So the damage to infrastructure is definitely affecting the water and sanitation. The limiting testing for microbes, and disruption to IPC and vaccination programs. Now, lots of disruption to vaccination in the country is taking place. As I mentioned earlier, healthcare providers are being pushed to use broad-spectrum antibiotics than before, and these are all leading to drastic evolution and spread of multi-drug resistant organisms, and this is something that will affect the global health, and not only one country or neighboring countries. As Carrie earlier mentioned, there is no one safe until we all safe. So شكرا جزيلا in Arabic, mother tongue is Arabic in Sudan, Diolchen Bauer, and thank you very much.
Wow, thank you very much indeed. If I can invite David down, please, we'll just get your slides ready. And so after David, we'll have some time for some questions and answers before we wrap up. Over to you.
Well, thank you very much. It's been it's a real privilege and a delight for me to be invited to come and present to you today. I think it's Hub Cymru Africa is a fantastic example of tremendous cosmopolitanism actions in principles in action. I think it's fantastic and needs to be copied by many other health authorities and health bodies. I'm here today primarily in my role as the president of the British Society for Antimicrobial Chemotherapy, or BSAC. And I got asked if I would like to be the president a few years back, and it's a fantastic organisation, so I was very, very keen to say yes. And then they said, what would you like to do during your presidency? What kind of project would you like to develop? And I'm a microbiologist as my day job, and over the last 25, 30 years or so in pathology in the United Kingdom, there has been this program of accreditation of pathology laboratories, including microbiology labs. And I've seen it work, and I've seen it work really well, because what it's done is got rid of all the kind of poorly evidence-based practice and made things much more efficient, effective, and most importantly, reliably accurate. So I've seen accreditation work in pathology labs. And I said, well, it seems to me antimicrobial stewardship is around in the world, in this country, in other countries, but it's not one thing. People do antimicrobial stewardship in lots of different ways. And it's very likely, it seems to me, that some stewardship is better than others. It's not to say that all stewardship needs to be the same, because it does need to be sensitive to the kind of context that you're working in. However, there are some very good general principles now in practice, and we should be saying, actually, some stuff isn't so good, other stuff is better. So I said to them, why don't we set up an antimicrobial stewardship accreditation scheme? And it taught me one thing fairly quickly, which you have to be really careful what you say to BSAC leadership, because they'll do it. And within a few days, weeks, they'd employed someone, they'd set up a website, they'd got everything going. I thought, better deliver now in that case. So that's what I'm going to be talking about. I've got no personal financial relevant disclosures, and just to mention that the BSAC accreditation scheme has been supported by a grant from Pfizer, Health Disparity Scheme, and also Baillie Gifford, who you may have heard of in the Baillie Gifford Book Prize, but basically their day job is making money. It's a financial organisation in Scotland, in Edinburgh, and but they've got a great charitable branch, and we've had 2 lots of money from them, and it's been really, really helpful. So I'm going to talk a little bit about AMR, about stewardship, and then a bit about accreditation. I'll skip over a lot of the slides in the first half now, because I think some of them are either identical or very similar to some of the slides we've already seen. And then I'll finish off with talking in more detail about the accreditation scheme. So it all starts off with this gentleman, Alexander Fleming, and the discovery of penicillin in 1928, and then clinical implementation from 1941 onwards. And of course, we didn't have any problems with AMR until then. However, AMR rapidly developed as a clinical problem very quickly over the next 50, 60 years or so, very closely coincident with the introduction of new classes of antibiotics. And if we haven't learned anything from this, then we're stupid. Because what this shows is that when you introduce a new class of antibiotics, within very few years, we're talking 2 to 5 years, resistance emerges and starts spreading. So putting all our eggs into the basket of let's just have new antibiotics is stupid. But resistance has been around for who knows how long, millions of years probably, because antibiotics are ancient. Antibiotics, penicillin came from a mold. That mold's been around for a long time. It's been producing penicillin for millions of years. We don't really know why antibiotics are made in nature, but I guess there's something to do with trying to eradicate competition from other soil organisms for scarce resources. But, you know, bacteria being bacteria and the drive of evolution and so forth, bacteria have developed resistance to antibiotics, and that resistance is ancient. And we know it's been around for a long time. There's a fantastic study published about 12, 15 years ago now, where the researchers dug deep into the soil in Yukon, frozen north permafrost, dug out some bacteria from there. These are bacteria that represented life on Earth 30,000 years ago, so clearly before antibiotics were used clinically. And these bacteria have genes for antibiotic resistance for a range of very useful modern-day antibiotics. And more up to date, some researchers dug up some medieval graves in monasteries in Germany, scraped the plaque off the dental plaque off the skeletons, and looked for bacterial genes and saw them there again. So antibiotic resistance is also ancient. But what we've done with antibiotics is create a superhighway for the development, for the promotion and distribution of antibiotic resistance. The other side of this particular coin is that there are no new antibiotics. The last antibiotic class to enter clinical medicine was discovered or described in 1987 when Margaret Thatcher was still Prime Minister, and that was daptomycin. We've seen this slide already. It just shows the global burden of antimicrobial resistance, and in particular the unequal distribution, particularly in the African continent. However, just to make an extra point here is that there are many people dying as well from the lack of antibiotics full stop. You know, antibiotic resistance implies that patients have been treated with antibiotics that aren't working. There are lots of other patients who are dying because they've not got any antibiotics at all. So we need to bear that in mind as well. So, and we've seen this one slide already. I think I'll just skip through that one. It's actually a really brilliant study, the meta-analysis looking at antibiotic use and AMR in primary care. But what we end up with there is some very reasonable, reputable people, not just shroud wavers, but people who know what they're talking about, post-antibiotic era in which common infections and minor injuries can kill, far from being an apocalyptic fantasy, is instead a very real possibility for the 21st century. Actually, I would go further than that. It's happening now. You know, we see patients with extensively drug-resistant organisms on a, if not a daily basis, regularly, and we occasionally see patients with pan-drug-resistant organisms. And they're coming from, many of them are, we see in Leicester, are patients who've come from other places, from South Asia, and most recently from Ukraine, but they are coming there here already. Which gets us on to antimicrobial stewardship, and we've heard a bit about this already, about what its outcome is. Really, we're trying to improve patient outcomes while reducing harm, including resistance. And in principle, it's really straightforward. You know, the way we use antibiotics, you start off with a diagnosis, you move to a prescription, you give the antibiotic, you review it. That's it. I mean, it's very straightforward, really. However, there's a lot of detail in here. Diagnosis, we've heard already today about, well, first of all, clinical diagnosis. Now, in my experience, lots of doctors from low and middle income countries are really good at clinical diagnosis. They have to be, because their laboratory systems are pretty appalling. And that's a big issue. And I think one of the questions earlier on about, you know, lack of laboratory functions is actually something which is not talked about enough. Whilst people talk about antimicrobial stewardship and infection control, the third part of this element, laboratory diagnosis, is often missing. And many, many hospitals around the world have virtually no access at all to microbiology laboratory capacity. And that is really problematic. Moving then on to the prescription, and again, that should be relatively straightforward, and things such as the AWARE classification and more recently the AWARE handbook, which is available for download from WHO, should support a lot of this. But this is a matter of education, training, and also monitoring, surveillance and feedback. And that's where a lot of what we commonly see as AMS going on takes place. The next bit, which is something actually I don't think anybody's talked about today, is administration, the role of nurses in antimicrobial stewardship. And it's something I think in this country we don't do enough. And I think globally we don't do enough. And I think that's a hidden resource we need to be tapping. Interestingly, I gave a talk at the Infection Prevention Society last year. And I thought I was really impressed with the title of the talk. It said, AMS plus IPC equals BFF, question mark. So antimicrobial stewardship and infection prevention control equals best friends forever. There's about 50 or 60 people in the audience. I asked them, how many of you, put your hands up if you're an infection control nurse. Virtually all of them put their hands up. Now keep your hands up if you have regular contact with your antimicrobial stewardship team. All but one put their hands down. There's a very significant gap going on there, which should be bridged very quickly, because we have a common focus between IPS and infection prevention control and antimicrobial stewardship. We're focused on predominantly antimicrobial resistant organisms, prevention and treatment, and it's something we should work collaboratively together on. We're missing a big trick here. There's also another bit we talked about, drug quality. I think that's a really important one, not just in low middle income countries, but even in this country. I think there's some concerns there. And then finally, the important bit, one that's often missed, is the review. People write the prescription and as if that's the job done, but it isn't, because of course sometimes the patients don't get better. We might get microbiology results which allow us to focus the antibiotics to a narrow spectrum agent. And so we should be thinking about, do we need to carry on with this antibiotic? Can we change another one? Can we stop? A lot of my job as a microbiologist is stopping antibiotics rather than starting them. We get a lot of phone calls, particularly out of hours, saying, can we stop the antibiotic? I said, well, it's up to you really, but tell me about the patient. And oftentimes we do. I mean, when I'm on call at weekends, I must start about 3 or 4 courses on antibiotics and stop or prevent a lot more than that. However, stewardship is more than just that individual patient care pathway. It's the governance structure around that, including education, surveillance, control in this persuasive and restrictive control. And as I say, that kind of organizational governance structure, which primarily is a quality improvement strategy. There are lots of different ways of carrying out stewardship, and we've heard a lot of these already, so I'll just go through this slide. But one of the big questions that always kind of troubled me to a large extent is, well, we're talking about antimicrobial stewardship and antimicrobial resistance. And whilst we know that antibiotic use drives resistance, it's not necessarily the case that stopping antibiotics reverses resistance. So that's the kind of different logical question. So I was really pleased to see this paper. And I must admit, I only saw it a few months back, although it was published in 2017. And it's a meta-analysis looking at AMS studies and showing very, very clearly that AMS does work at reducing infections with multi-drug resistant bacteria, both gram-negative and gram-positive. However, and this is a really key point, and one that reflects what I've just talked about, stewardship programs work far, far better when combined with infection prevention interventions as well. So that's something we really do need to take measure of. So let's get on to accreditation. What is accreditation? It's a self-assessment, first of all, but then an external peer review of health and social care organisations looking at various levels of practice. So it's been around for a long time. It's based on published standards. Reviews are conducted by professional peers, administered by an independent body, and the aim is to improve, to encourage organisational development. Now, I've talked rather generically about it here up to now. And, well, let me just, before I get to my next sentence, let me just put this in. There are sometimes a bit confusing. People kind of think about accreditation and registration and licensure and certification. They're not quite the same thing. So, for example, in England, CQC registers hospitals to allow them or licenses hospitals to allow them to provide healthcare. But that's not accreditation. It's not really looking at a quality improvement. But accreditation really does have this aim of driving up standards of practice. It started off over 100 years ago with a scheme set up by the American College of Surgeons, setting out minimum standards for hospitals. It spread across North America and to other countries, Australia, Europe, and has subsequently, accreditation programs have developed in many parts of the world, most of them focusing on whole hospital activity rather than individual topics. However, there are accreditation schemes which do focus in on limited elements of clinical care. Why do it? Well, it's often driven by ministries of health, non-governmental organisations who are responsible for the judicious use of resources, particularly if they've been raised through charities. Also by WHO and Pan American Health Organization, as well as other financial and aid organizations, because accreditation really is a marker of quality, that people can use this as knowing that their money is being well spent and well directed. It helps ensure the quality and cost effectiveness of healthcare. And as I say, it's a kind of surrogate for due process. Instead of all those organisations going around and doing their own inspections, if there's a reliable accreditation programme and a healthcare organisation is accredited with that programme, it gives them some kind of assurance that their support for their organisation is worthwhile. And some aid donors actually require accreditation as a basis for support. For the organisation that's being accredited, there are some significant benefits, particularly financial benefits, including maybe getting more money for the same amount of work, so reimbursement differentials. Also, potentially, if insurance companies are the commissioners of healthcare or the payers of healthcare, then being accredited will allow them into that kind of market. They may well have a preferred provider status. And a lot of countries in low-middle income, a lot of hospitals in low-middle income countries, we kind of think, we're using the term low-middle income countries and kind of broad-brushing all hospitals in those countries as one type of organisation is very misleading. There are some fantastic, beautiful hospitals that I would love to be treated in low-middle income countries. They're often in the capitals, they're private hospitals, and they're often a focus for medical tourism. So, you know, we should think about the heterogeneity of healthcare provision in low-middle income countries. It's not all the same. But being an accredited hospital, for example, with Joint Commission International as a whole hospital, allows you to be, I think, a reputable medical tourism destination. So there's lots of good reasons. Accreditation standards are key to accreditation. They have to be relevant, understandable, measurable, behavioural and achievable, so the RUMBA acronym. And does accreditation work? Well, there is increasing evidence that it does. In my personal experience, it's worked really well in pathology services in the UK, but a more measured approach shows, in fact, there's definite evidence, systematic analysis, meta-analysis, shows that you can demonstrate improvements in efficiency, safety, effectiveness, patient-centeredness, and timeliness of healthcare. So 6 really good areas of health improvement. So it does work, I think, to a very large extent. Within the UK, we have a number of accreditation schemes already. I mentioned the laboratory standards, but also Joint Advisory Group on GI Endoscopy, the JAG accreditation. The medical labs 15189 and so on. You can see all these yourself. And what surprises me considerably is that there aren't any more accreditation schemes. I think there are many areas that are ripe for accreditation. I was talking to one of our intensivists a while back, and I said, you know, is there an accreditation scheme for intensive care units? And she goes, no, why would you do that? And I said, well, you know, you're all pretty much the same. You've all got patients on ventilators, you know, you've got the provision of care. Why aren't people going round intensive cares, peer reviews and saying, well, you're doing well, you're not doing so well, and things work, there are areas where you can improve. A fresh pair of eyes, I think, is a really useful bias. It's a positive bias. So CQC actually have on their website, we will use accreditation schemes that relate to a particular service to inform our inspection activity and enable us to take a proportionate approach. What that means is if you're JAG accredited, they're not going to go and visit your gastrointestinal endoscopy unit. We don't get accredited, we don't get visited by CQC because we're UCAS laboratory accredited. So I really want to kind of antimicrobial stewardship accreditation scheme on that CQC list, which gets us onto GAMSAS. Now, let me tell you first of all, this is secondary care focused. We don't have the resources yet to look at primary care, but it is something we do get asked a lot about, and it's something I'm sure we should do at some point, but not just yet. So, what is it? Well, its aim is to support healthcare organisations build and sustain good antimicrobial stewardship programs. So if you've got a good scheme already, it's an opportunity to demonstrate that using an objective visit and to say, look, we've been BSAC accredited, GAMSAS accredited, and they say we're good or whatever. So, but if you don't have a well-established AMS scheme yet, it's an impetus to get that up and running, and because we will support. We've got really good resources to get people get their AMS schemes going. It also contributes to National World Health Organization's AMR action plans to help drive up stewardship practice. There are some other additional aims for this. We want to identify areas that repeatedly need improvement across organizations across the world, and to address these by developing and delivering education and quality improvement interventions. One of the big things that BSAC is really good for is education. We've got some fantastic online resources that are available for anybody to view, freely available, and some of them have been mentioned already. AMS Antimicrobial Stewardship in Africa, hosted on the BSAC website. We also want to create awareness in healthcare payers, whether it's the government or insurance companies or even individuals, on how variation in stewardship affects the quality of care that they're paying for and how this can be improved. And we wanted also, thirdly, we wanted to provide it's an input into developing an oversight of problems with antimicrobial stewardship across the world. What are the limits? What are the barriers to improving stewardship further? Is it financial? Is it government support? Is it lack of people, lack of training? So all these things that we need to look at and so that we can understand and develop policies which will address these deficiencies. How do you go about getting accredited? Well, the first thing is to complete an online screening questionnaire. This will then tell us where you are on the stewardship path and what you need to do. And if you really only just started, we will say, look, you need to do a bit more work yet. Go away with, these are some resources that you might find useful. Have a look at them, see what you make of them, come back when you've looked at that, and so on. But we will also provide support anyway. So the BSAC GAMSAS team reviews that survey. We then do a more in-depth one to get all the information we need pre-visit. So we go through all that to make sure that the visit is going to be worthwhile. And it looks at mostly antimicrobial stewardship, but it also looks at microbiology laboratory service provision and infection prevention practice as well. And then we do the visit, and then we report back to the GAMSAS board, and the panel comes to a conclusion on to whether or not the organisation is accredited. Now, the accreditation is in levels 1, 2, and 3. Level 1 is pretty basic. Level 2 is, well, the Lagos University Teaching Hospital that we saw mentioned earlier on, that achieved level 2, which is very good. But there are some organisations which are absolutely superb. You go and see them, you think, well, it's very difficult to see how they could be better. And we really have to kind of work hard on trying to find some areas of criticism. And we're very pleased when we pick up something that they haven't done. But, you know, everybody can improve. And then, if an organisation is acting as a local leader for stewardship within their town, within their city, their region, their country, providing support for other organisations, then they will also get a Centre of Excellence award as well. And an example of this, we went to a hospital in Kentucky, and they were really excellent, fantastic service. And more than that, they had this network of community hospitals, which were very small hospitals, didn't have their own antimicrobial stewardship teams, but they were able to train up personnel, mostly nursing staff, to act as antimicrobial stewards in those hospitals. So they were absolutely first class. You can't be much better than them. These are some of the things we look at. I won't go through them in much detail, but the major thing here is the four major headings: structure, so the governance structures primarily; guidance, what kind of guidance is available for prescribers and administration of antibiotics; education and training, and then finally surveillance in terms of antimicrobial use and antimicrobial resistance. And we also have questionnaires and surveys of IPC and laboratory practice. So I mentioned about the GAMSAS panel. We've got an international board. We've got people from many different countries on the board who review each visit result and agree on the outcome. We've got the BSAC education resources I've already mentioned. And as I said, we encourage organisations which aren't yet centres of excellence but have received their accreditation to become centres of excellence. An example here is there was a hospital in Liverpool, a neurological hospital, and they were saying, well, it's very difficult for us to partner with other, we're pretty unique as a neurological hospital. I said, yeah, but lots of hospitals have neurology departments, neurosurgery departments. They are facing similar problems to you, but it's just within a different setting. You could be linking up with those individual departments and supporting their practice. So far, we've got, I think, 5 hospitals in England accredited, and you can see what they are there. And I think at least five in other parts of the world. So we started accreditation last year. So this is our first harvest, so to speak. We opened up accreditation applications for accreditation late last year. We've got a book of people waiting to be accredited now, or hospitals to be waiting to be accredited in many parts of the world, including England. And we're in discussion with Nick Reed, who's the Public Health Wales antimicrobial pharmacy lead, to see whether or not we could get Wales involved in accreditation. Let me just try very quickly see if this works. This really kind of almost brought me to tears, actually. We did this accreditation visit in Lagos, and then we went through the panel. We came to agreement that it was level 2, and then we reported back to them.
Antimicrobial resistance resulting from abuse of antibiotics is a growing global health concern, particularly among medical experts who are currently working out measures to tackle it. There is, however, good news for Nigerians, as a federal government-owned health institution, Lagos University Teaching Hospital, LUTH, has met the requirement by the British Society for Antimicrobial Chemotherapy, BSAC, Global Antimicrobial Stewardship Accreditation Scheme, GAMSAS. Our correspondent reports that Lagos University Teaching Hospital is the first teaching hospital in Nigeria and Africa at large to be BSAC Global Antimicrobial Stewardship certified.
So it goes on for a few minutes, and for sake of time, I'll just stop it here. But this was national news on a Friday evening. I thought it was absolutely wonderful. We got sent the link, and to give LUTH Hospital, Lagos University Teaching Hospital credit, they're very good at PR. So they did a fantastic. They gave us a great visit. There were some fantastic events. There was suddenly this lady was giving. She was there, Professor of Microbiology. She was leading she leads the antimicrobial stewardship team. She was giving her presentation. Suddenly everything went dark, and I thought, oh, presumably this is fairly normal. And they said, no, we don't usually have blackouts like this. Anyway, after a few minutes, the lights went back on again. later on that day, they showed us some photographs of why the electricity had gone off. There was this big snake that had crawled into a relay station and it triggered the totally fried snake now. But I was disappointed they didn't bring the carcass. But anyway, it's very interesting because there was a question earlier on about the role of pharmacists in antimicrobial stewardship in some countries. It was clear during the visit there was some kind of tension between microbiology and pharmacy. And it was interesting seeing it. It looked like it was being resolved in front of our eyes. A very interesting experience because of, I think, of this accreditation visit. It was quite amazing. Anyway, we'll see how it goes. So there we are at the moment. Just mentioned about the Pfizer scheme. This was a scheme that's funded by Pfizer to try and improve health disparities around the world. You might think, well, why on earth would Kentucky be involved in this? Actually, in eastern Kentucky, in the western Appalachian Mountains, there's some really deep poverty, and they have big problems there. So it's very interesting to see that. Other hospitals are in areas that you might expect to see when we talk about health disparities, and their projects, most of those are projects in progress, but with intentions to visit some, if not all of them, this year. So I said the next accreditation, that was launched last December. We're training more assessors both in UK and abroad. We're looking at research proposals to identify measure factors influencing effectiveness and sustainability of the GAMSAS scheme, with the intention of producing a wider report. And following on from this, I keep saying to people, it's not an event, it's a progress, it's a process. Stewardship isn't something that should be just done for the day of the inspection. It needs to be happening every single day of the year. So the GAMSAS scheme is a relationship rather than a visit. And although we do go and see people, but the ability now to communicate effectively using Teams and so on means that we can now bring these organisations together across the world to share answers, share problems and answers. It's really quite amazing. One of our, I was so impressed when on one of the Pfizer meetings we had with 10 hospitals around the world joining in, people just started talking to each other and saying, oh, how do you do that? Oh, we've got this scheme. Oh, brilliant. Can you share that? And suddenly all these solutions were being shared globally. Really tremendous. So anyway, that's it. Final slide, British Society of Antimicrobial Chemotherapy. It's a small organisation which punches well above its weight. It's British by name, but global by outlook. Nearly half of our 6,000 members are overseas. Membership is free to anyone who has an interest in antimicrobials and antimicrobial resistance. All you have to do is go and follow that link and fill in the form, and you'll get free membership. So I hope, if you're not a BSAC member already, that you will consider applying and joining. Thank you very much.
Dave, thank you very much indeed. So we will have some time now for questions from the floor. So do look at your scribbled notes and be formulating a few questions, and then we'll just come to the end and I'll ask Julian to do some wrapping up and talk a little bit about evaluation and where we go from here. So, questions from the floor, please. Such a rich number of presentations today. We've got a lot to go home and think about. Any questions from our students I particularly want to ask, because this has been a new topic for some of you, but I know many of you are often in Harad or Sue's classes at the moment. Okay, that's why you're having a little thing.
Thank you. That's fascinating, and congratulations on the work that you're doing there. And you've come back a few times about this. It's easy to tackle some of this stuff in hospitals, but out there in primary and community and outpatient settings is probably where there's more of a problem just because it's, you know, everything's just bigger, there's more antibiotics out there. Is there any way you can see to kind of offer that accreditation to an organisation now, particularly in the UK and many other countries, are kind of scaling up primary care? So in England you have primary care networks, so you have an organisational level, because it's quality improvement. I'm looking at my GP colleagues here, that certainly in the UK we've got brilliant electronic records. I mean, data availability is better, I would say, in primary care than in secondary care. So you could do your point prevalence survey in 10 minutes probably, rather than going through individual patient records. So the opportunities are there, but we don't seem to be gearing what we're doing because everybody thinks it's too complicated. Can you see a way to kind of bringing some of those techniques that you use at corporate level into the more messy but richer primary care setting?
Well, it's certainly the case in the UK that the large majority of antibiotics that are prescribed in primary care. I think it's about 85% or so, something like that. So it's clearly something we should be looking at. On the other hand, by necessity, virtually all antibiotics prescribed in primary care are orally administered, are those antibiotics that can be given by mouth, which does limit the range, both in terms of the kind of names of the antibiotics, but also the antibacterial spectrum. So that is, whereas in hospitals, of course, it's both orals and IVs and some very broad spectrum antibiotics, particularly the cephalosporins, carbapenems. So it probably our focus on secondary care is there's probably a number of reasons, but one of them would be, of course, I'm a microbiologist. I work in a hospital. My experience of delivering healthcare is hospital-based. We don't really have this well-developed feel for primary care as hospital-based microbiologists. I know we get involved in drawing up prescribing guidelines for primary care, but there tends to be, unless you're very interested in it, tends to be a bit of a kind of almost an afterthought. I mean, it'd be interesting to see what Harrod's view on this is, because I could see what your perspective there is. I think we ought, but going back to that point about most antibiotics being prescribed in primary care, it clearly is something we need to look at. And how we would do that, I don't think I've got the skills. The people I talk to don't have the skills because we're all secondary care. I think we need to engage with primary care a lot more to try and develop something jointly there. I think it's not something that we could do alone.
I think that's essential. You know, three of us here started in practice 40 years ago and joined partners who had been there for 20 years. Now, they'd started off their careers in practice seeing children die from pneumonia and infections in the pre-antibiotic era. And understandably, they saw the wonders of antibiotics and thought that they were risk-free.
Yes.
And so the threshold for prescribing antibiotics was very, very low, which led to the population expecting and demanding antibiotics for minor illnesses. Now, we spent 35 years trying to counteract that and telling patients who need antibiotics for your child's cold. And I think we were quite successful towards the end. But I get the feeling now that with pressures that are on general practitioners, and with the move away from face-to-face consultations and telephone consultations, my feeling is that the use of antibiotics is rising, which is terribly disappointing for people like us who've been fighting this battle for years. So I think, in answer to your question, I think general practice is an area where this approach would be very, very useful and necessary. And I would suggest the way into this would be to approach Health Education and Improvement Wales, HEIW, that control postgraduate medical education. I worked with them for years in the Department of General Practice, and I think that would be very useful discussions could be held about introducing maybe not your accreditation scheme to start off with, but maybe to raise awareness of antimicrobial stewardship and introducing that into the sort of general practice group.
Hey, what's your, how new is, I mean, how novel a concept is stewardship, antimicrobial stewardship is to you in primary care? Is it something you're well aware of? Or?
Yes, but for years and years and years, but not formally.
There are now a lot more pharmacists employed in primary care than there ever were. It's been an explosion in the last 5 years. And that in here at cluster level, England, in PCN level, so that wider primary care, but pharmacists are probably the most useful addition to the wider primary care team, and that's a really big part of their role, is rational use, wise use of medicines, but antibiotics have been the top, really, haven't they? And there's been formularies and education and so on. So quality improvement, I think, is something that we do in primary care quite well. And that behaviour change, is something, because that's part of the day job. You're continuously trying to help people change their behaviours to become more healthy. So I just think there's a lot of opportunity, and it's if it can just be adapted, because it's very easy to do an accreditation scheme for something that's corporate and has a boss and a hierarchy. But to transfer that into a primary care setting where you might have more impact, but it needs to be flexible. And I think that's something that globally probably needs to happen as well, be more flexible to what happens outside the fancy shiny hospitals where...
And it certainly is a challenge, I mean, not just in secondary care, but in primary care as well. There have been a number of initiatives over the recent years to try and rein back prescribing in primary care. And they tended to be successful, but just for a few years, and then things slip back. Maybe because of COVID, and of course COVID has led to a lot of remote consultations and prescribing. And that's true not only from primary medical care, but also primary dental care as well. And big increase in antibiotic prescribing in dental care during COVID. We heard recently at a Clostridium difficile meeting that a lot of this was totally unnecessary and inappropriate. So there's a lot of work to be done. So yeah, absolutely. It's on our radar, but not close, to be honest.
Just to add, Public Health Wales does have a lead antimicrobial pharmacist for primary care at the national level, Meryl Davis, who is doing fantastic work with community pharmacies, general practitioners, and other staff in community settings on antimicrobial stewardship, and produced a raft of resources. We have also, I sit on the Public Health Wales Antimicrobial Delivery Board Education and Training Workstream. We've produced an e-learning package for primary care through HEIW, that's available on HEIW's website for all people prescribers in primary care. So there is work being done around that, and Kerry might know more as well about this, but there is some activity. Of course, it's never enough, and it's probably not as high profile. What would you say about that, Kerry?
Yeah, there is a lot of work ongoing. There's a lot of data that is needed because the complexity of primary care is huge. So as you say, there has been moved towards remote consultations. We've actually seen a move back to face-to-face for infections. That's been supported by NICE, thankfully. So actually we're now back to pre-pandemic face-to-face consultation levels, but actually our antibiotic use is still rising. So actually our latest kind of quarter 3 data shows an increase in the 2019 quarter 3 data. So, there's lots of issues in terms of staffing and everything. My health board has got the highest.
Can you speak up a bit?
My health board has got the highest variance in primary care antimicrobial prescribing in Wales. So we've got Newport, who are really low prescribers, and some of the valleys communities that are very, very high prescribers. And we've gone to Newport and said, what do you think actually makes it low? What can we learn from you? And they said, oh, we've actually got a lot of, because we've got such staffing problems, we've actually got a lot of non-medical prescribers who are more likely to stick to guidelines than clinicians are. We're like, well, we can't therefore just use that as an approach. So we're now going to go into some of the other practices that maybe have a different skill mix and see what we can learn from them and implement elsewhere. The complexities of primary care are huge, but yeah.
Sorry,
accreditation would be good.
So this is not a question I was going to ask, this point being raised. Surely prescribing is one side of the coin. The other side of the coin is the actual use by the patient and somehow monitoring what they are doing. I don't know if there could be some kind of indirect way of finding out by asking for the person to, within after the period has taken the antibiotics, to return the said packet to the surgery, which then can be seen whether or not the person has actually taken the whole lot. They won't say that they're monitoring the person, because otherwise the person may then throw away some of the pills, etc., etc. Just seeing their use to see whether or not the person's actually done it. And they'll say, well, we need to collect these things, which then of course be passed on to the pharmacy afterwards. There must be some way worked out to see if the person is actually using them correctly.
There is an issue here that there are two things which have got conflated in completing the course, the mantra complete the course. One is to try and prevent incomplete treatment, and that's why people are told to complete the course, because there is a temptation once you start feeling better to stop altogether, and then you might get a relapse. However, from an antimicrobial resistance perspective, shorter courses are much better. And the duration of course length is probably the least understood or least studied aspect of antimicrobial prescribing.
It's always a week.
It's always a week. It's 7 days because it's a week. Yeah, so it's a week. 5 days. So we
3 days.
We get 3. I mean, so we have. We have a code system in Leicester where certain antibiotics you can't get at all without a validation code before prescription. Other antibiotics, if you want to give more than 5 days, then you have to get an extension code. And it was 5 days just because that we felt if it was 3 days, we just wouldn't cope with the workload, and 7 days would be too long. So it was very arbitrary. But that's as arbitrary as saying give a 7-day length of treatment. It's very, and it's interesting. Sally Davis, was the chief medical officer, she wrote this book, co-authored a book called "The Drugs Don't Work," and she actually said, "Oh, we must complete the course." This is spurious. Very interesting that it's.
So has it not been determined what should be best practice?
The practice should be that you give long enough and no more.
Exactly.
And everybody in primary care in this room who has visited patients at home and looked in their cupboard has found hundreds and hundreds of drugs, of courses either never started, because they had more sense than the doctor who prescribed it, or not finished.
Well, Theresa Coffey, who was health minister for a few days, she announced that she would often hand around unused courses of antibiotics to friends and family. Bizarre, isn't it?
I'm sure you're aware of it. There's a website based in the US called Shorter is Better.
Yeah.
Google that, and that has lists of all the evidence of where the shortest course you can get away with, and always, whenever they do a study, it's always the shorter one is sufficient. So
yeah. And when I started in microbiology down in Brighton, we had post-operative prophylaxis in vascular surgery, which was antibiotics for 2 weeks. Yeah. Kill you after just think of that. It's just making you shudder. I can tell, isn't it? Yeah. 2 weeks of antibiotics for someone who hasn't even got an infection.
Is it very variable between different antibiotics and between different infections? That, 2 days, one mega shot of one is enough for one thing, and then you need 6 months for TB. And
well, so for TB it's better studied. But the thing about infection is it's very difficult to know when you've actually treated a patient. When I say treated, I mean eradicated the infection, because infection, the disease that we experience is made up of two things. One is the initiation of it, the bacterial pathogen replication, and then the other aspect of it is the body's inflammatory response to that. And the inflammatory response can last a lot longer than the active replication once you start treat the patient with an appropriate antibiotic. I mean, I've seen studies where a single dose of antibiotic is sufficient for bacterial meningitis. It's, chloramphenicol or penicillin in oils or some kind of long depot preparation of antibiotics. Chloramphenicol was there, I think. So, a single dose may be enough. Maybe it made the pharmacokinetics, maybe that it lasts a bit longer. But, the patient might still feel very unwell and actually be quite ill, but not because of active pathogen replication anymore. It's because of the inflammatory process that's still ongoing. I mean, you must have experienced this yourself. You bang yourself, you get a swollen thumb or something like that. It stays swollen for days or weeks. No infection going on. It's just bruising and inflammatory cascade.
In other words, ideally, you'd have to get the patient in to see whether or not there was any need for further use of the antibiotics, or not.
Well, even in hospitals, it's very, very difficult. I mean, people look at the CRP and so forth, and temperatures. I mean, it's very much a judgment call.
And I think this also underlines the importance of diagnostic testing, because that can depend, the length of antibiotic that you need can depend not just on the clinical condition, but on the actual organism that's causing it. So if you don't know the organism, you don't know how short you can get away with. I mean, your meningitis example, meningococcal meningitis doesn't need very long at all. Pneumococcal meningitis does, but without a lab result, you don't know which one it is.
No, absolutely, absolutely. And things like meningo, you can 99.9% certain it's going to be pen sensitive. Whereas pneumococcus, in some parts of the world, probably not. Could be multi-drug resistant. Anyway, I could talk forever on this.
I know some of you have got further questions, but it's always better to leave the audience wanting more. Julian, can I invite you up to please tell us about evaluation?
Yes.
That would be really helpful.
Yes, you can.
So while Julian is doing that, I will invite people, just if they are going somewhere or knowing somebody who's hungry or whatever, do take one bag if there's anything spare or from the crate as you leave. And Julian will tell us about evaluation.
Yeah, that would be great. It's very important that we monitor and evaluate and attempt to learn from the events and the activities that we do. So I would please ask you all to complete an evaluation form. Simeon, my colleague over here, has all of these forms and can distribute them, and has been instructed to stop people leaving unless they handed back an evaluation form. It will only take you, 20 seconds probably, so please have a pen to hand and fill in one of those forms. If you would like to stay in touch about these issues, you're not already on the Hub Cymru Africa mailing list, then I have a rather more old school, again, bit of paper. Please do fill in your name, email address, and we can add you to our mailing list to get emails regularly from Hub Cymru Africa. And as I said at the beginning, there has been a little bit of discussion about possibly a kind of Welsh-based international community of practice looking at antimicrobial stewardship. We haven't discussed it very much. If you are interested in getting involved in such a thing, then please do put a tick in this box saying sign up for more information about a community of practice. And if we have, I don't know, if we reach the threshold of 5 people saying they're interested, I'll pick that number. If we have enough people interested, then we will basically get those people together for a meeting. We don't really have an agenda or a plan. So if people are interested in doing it and you think you've got some ideas, then put your name down here and we will get everybody together and you can talk more about how that might work. I think that's it, Julia, for me shouting. Is there anything?
No, I think that's grand. Just make sure you do, please, do your evaluation form. I'd like to thank everybody very much for coming. I'd like to thank all our speakers. I'd like to thank Hub Cymru Africa and Welsh Government for funding one of our shared learning events. And it just leaves me to say, have a safe journey home. And thank you very much.